Good morning, everyone. My name is Ala Kamil, and I'm serving as the designated federal official to the U.S. EPA Science Advisory Committee on Chemicals, which we call SACC. For this meeting and in my role, I will be opening the third day of the public meeting on the SACC's review of EPA's draft risk evaluations for dibutyl phthalates, DBP, dicyclohexyl phthalates, DCHP, and di-2-ethylhexyl phthalate, DAHP, and the technical support documents for butyl benzyl phthalate, BBP, and diisobutyl phthalate, DIBP, and the cross-phthalate human health benchmark dose, BMD, analysis, cancer analysis, and cumulative risk assessment technical support documents. I would like to repeat that SACC meetings are subject to all FACA requirements. These include open meetings, timely public notice of meetings, and document availability to the public. All documents are available to the public in the dockets at regulations.gov. As a reminder, this meeting is being webcasted, transcribed, and recorded. A live stream of today's meeting is available on YouTube, and you can see the link on the meeting's website. I would like to thank Dr. George Cobb and Dr. Robin Ann Gentry for facilitating the sessions yesterday. And I would like to thank the committee members and ad hoc reviewers as well. And I would now hand it over to the chair who is facilitating this session, Dr. George Cobb. George?
Thank you. Thank you, Dr. Kamil. And it's a pleasure to have us all back together today. Thanks to everyone for joining us from the public and to EPA for getting all of these documents ready for us and the charge questions prepared. We got a lot to do. We made a lot of progress yesterday. We gapped our agenda a little bit, so we're going to have to go back just as a reminder for the EPA folks and the AV folks. We're going to be at 5E when we start. But the first thing we need to do is take the roll, and I've got to get my roll pulled up. I got too many
Dr.
things.
Cobb,
Yes.
I think we're starting with 5F. Sorry to interrupt.
5F. Well, that is even better. We're further along. I thought 5F, but I got an email about 5E, but that is fine. We will do 5F. Thank you for that clarification. Now let's look at the roll for today. And we'll start with Dr. Chason.
I'm here, thank you.
And then Dr. Ike.
Good morning, I'm here.
And then Dr. Fong.
Good morning, I'm here, thank you.
And Dr. Fox.
Good morning, here.
And Dr. Gentry.
Good morning.
And Dr. Graham.
Morning.
Dr. Hager Bernays.
Good morning.
Ms. Jenkins.
Good morning.
Dr. Lee.
Morning.
Dr. Merced Nieves.
Good morning.
Dr. Ottinger.
Good morning.
Dr. Semmel.
Good morning, I'm here.
Dr. Wright. No, he is not here today. Dr. Babbage.
Here.
Dr. Chang.
Right here.
And Dr. David.
Here.
Dr. Fanny.
I'm here.
Dr. Martinez. Thought I saw her. Janelle?
She's on screen, but on mute.
Can you acknowledge that you're here, Dr. Martinez? Okay, we can circle back. Dr. Spade?
Here.
And Dr. Wolf.
Present.
Dr. Martinez, can you get off of mute, perhaps? Aha. No, And did I miss some? Dr. Rowlands, I'm sorry, I missed you.
That's okay. I'm here.
Okay. All right. Well, we've got enough folks so we can proceed. And as we usually do, before we go into the charge questions, I'll ask to circle back for all of the, we asked everyone to perhaps think through whether they're, I'm sorry, I'm getting announcements through the Zoom. So I think Dr. David had a comment from yesterday, and then Dr. Wolf had a comment from yesterday, and then we can open it up to others on the committee that may have thought through things that we need to discuss today. So I'll turn it over to Dr. David.
Thank you. So we ended yesterday with a discussion of charge question 6B, and we were going back and forth about thresholds, and there were a number of articles, one by Jim Klonick and a group that Dr. Babbage pointed to, and that was uploaded into the SharePoint. I went back and looked at that article quickly, and I extracted out a table that was in the paper that what Dr. Babbage was referring to, and that triggered a suggestion to me to add to the discussion the actual incidence of tumors from the chronic study. So I happened to extract that and put that just in our summary response, not that it is going to be there forever, but it allows people to compare the tumor incidence and the other markers that Klonick et al. Had focused on. I also started to think about thresholds and trying to come up with criteria for thresholds based on what Dr. Babbage had mentioned, that the results don't point to or discount thresholds. And I remembered an ILSI group that looked at what they call dose-dependent transitions, which essentially are thresholds that through a variety of mechanisms. And so I put those papers into the SharePoint, which I suggest that the discussants may want to look at. And one of the case studies is PPAR, in fact. So that may be pertinent to the response that we put together. So after people have had a chance to look at that, perhaps we can get together as a small group and discuss it. Thank you.
Thank you. That's good information for us all to consider. And Dr. Wolf now had some things from yesterday as well.
Yeah, so my interpretation of what was discussed was really focused on the Palmitel-CoA data in the Klonick paper and the concept that that was linear and therefore you couldn't identify a specific threshold. And so I went and took a look at those data in a little bit more detail. And if you bear with me just for a few minutes, while Palmitel-CoA can be found in other organelles and in the cytoplasm, so you would expect if it's responding to something, it could respond to other organelles. It also resides in the peroxisomes, and it historically has been used as a biochemical marker of peroxisome proliferation. It's important to remember that neither Palmitel-CoA nor peroxisome proliferation are no longer thought to be key events in the mode of action for PPAR alpha agonist tumor development. So peroxisome proliferation is a thing that happens and it can be considered an associated event and measurable and quantifiable, but is not on the pathway and the adverse outcome pathway from chemical exposure to the tumor. The greater the enzyme induction, there would be an association with a dose to the liver that's also driving the tumorigenic mode of action. So again, it could be an indicator. While palmitil-CoA induction and thus peroxisome activity may be proportional to the tumor response, as stated in Clownig et al., to quote, increases generally are not above background or control levels at low exposure. So I took a little look at all the tables, tables 3 to 9. So if you look at just the control animals across that, and I presume since this is a group, all the enzyme induction assays were done in the same lab. So I think it's reasonable, like you would in clinical pathology, kind of look at across all the control data. So the rat activity as nanomoles NADH formed per milligram protein per minute ranges from approximately 2 to 16 in controls, in the control rats. In the mouse, that same value ranges from 3 to 7 in the controls. So that is the general range, 2 to 16 and 3 to 7 in the controls. If you just look at the phthalates in the data, the DEHA, the two lowest doses of 144 or 282 milligrams per kilogram per day in rats had no increase in activity. The two lowest doses of 343 or 808 in mice had minimal increases in activity within the range of all the control mice. So while it was significant in that table, if you look across all the control mice, the change in enzyme activity was within the general range reported from all the tables. BBP, the lowest dose of 650 milligrams per kilogram per day in rats, had a minimal increase activity, again within the range of all the control rats. DEHP, the low dose of 30 milligrams per kilogram in rats, had no increase in activity, and DEHP at 20 milligrams per kilogram in mice had no increase in activity. And then DINP at 625 milligrams per kilogram in rats, no increase in activity, and DINP at 125 milligrams per kilogram in mice had minimal increases in activity, again, within the range of all the control animals reported in Clownig et al. So for the phthalates within this collection of data, while increase in activity may be linear in the higher range of doses above 100 milligrams per kilogram, at doses below 50 milligrams per kilogram, there were no differences from controls. Comparing the phthalates to the PPAR alpha agonist drugs of ciprofloxacin, clofibrate, and the LI 171883 model drug, the phthalates are far less potent PPAR alpha. So the phthalate data in here, again, suggests that there's a point at which there's no enzyme activity response, and thus we would term a threshold response for that activity as well for the phthalates. The drugs are a little bit different because they're created to target that particular asset. So I put this into the 6A and 6B folders, and that's my comment. Thank you for the time.
Okay, thank you for the comment. And then I see that Dr. Heiger Bernays has her hand raised.
Yeah. Can I speak?
Oh, yes, please.
Oh, okay. Thank you, Dr. Wolf. That was really informative. Can you remind me which paper that was in that is now in SharePoint?
That's the Clownig et al. Paper that was discussed at length yesterday when we were doing 6A and 6B.
Okay, so this was interpreting.
This is interpreting. This is a little.
All right.
So my interpretation, looking across all the tables. So each table is a separate experiment, and as appropriately you would analyze each experiment. But when I looked across all the control data, it was a bit broader, and that to me that's the thing. What's the lab control, like you would with clinical pathology data? What's the typical range of control data? So.
Okay. So thank you. And thank you, Dr. David, for incorporating that table. I did not have the opportunity last night to review. If it's okay, I'd like to take that time today and then have that discussion that you're proposing, maybe a breakout session, whatever. That would be very helpful to me.
Yes, I am proposing a breakout session perhaps tomorrow to give you an opportunity to read through some of the documents that are in there.
Okay, thank you.
All right, thank you for that discussion. And yes, I think breakout sometime tomorrow for that charge question group would be good, and maybe a quick summary of what that outcome was back to the committee would be good. And I apologize if my phone went off. I had not silenced it, and that was my phone, full disclosure. Any other comments from the committee? Mary Fox, please proceed.
Yes, hi, Mary Fox here. So I'm circling back to clarification that EPA requested, and this is for charge question 5C1. There was a comment about the Larson et al. 2007 study, and EPA asked if that was one of the co-exposure experiments, and yes, it was. So we'll make sure that we clarify and revise the comment on 5C1.
Okay, great. Thank you very much. Any additional comments? If there are not, then we can proceed to question 5F and have one of our EPA representatives read this into the record.
Morning, everyone. This is Anthony Luz with EPA. I'll now read charge question 5F. In the draft meta-analysis and benchmark dose modeling of fetal testicular testosterone for DEHP, DBP, BBP, DIBP, and DCHP, EPA conducted an updated meta-analysis and BMD modeling analysis of decreased fetal testicular testosterone in rats. The analysis represents an update of the analysis conducted by NASEM in 2017. As part of EPA's updated analysis, EPA conducted modeling using Metaphor version 2.0.0, which is a version originally used by NASEM in 2017, and version 4.6.0, which is the most recent version available at the time of EPA's updated analysis. We evaluated benchmark response, our BMRs of 5, 10, and 40%. NASEM evaluated BMRs of 5 and 40%, and included newly identified fetal testicular testosterone data. Overall, EPA selected BMD modeling results obtained using Metaphor version 4.6.0 for use in the single phthalate risk evaluations and phthalate cumulative risk assessments, because these results were obtained using the most up-to-date version of the Metaphor package available at the time of the updated analysis and BMD modeling analysis. Please comment on the strengths and uncertainties associated with the methods and data used in the updated analysis. In your response, please comment on EPA's preliminary decision to use model results obtained using Metaphor version 4.6.0 versus version 2.0.0. Thank you.
All right, thank you very much for getting that into the record, Dr. Luz. Dr. Gentry is our lead discussant for this.
Okay, thank you, Dr. Cobb. The approach EPA used relies mainly on a previous meta-analysis and meta-regression approach conducted by NASEM in 2017. A more recent version of the meta-analysis package for R or Metaphor that was relied upon is available. And as mentioned, EPA also calculated additional benchmark dose. The use of Metaphor allowed EPA to combine data sets for each phthalate. Further, the use of an updated Metaphor analysis with addition of more current data on fetal testicular testosterone allowed EPA to verify the model and results for a key component of the phthalate syndrome. While EPA has demonstrated that the application of the more recent version of Metaphor has little impact on the results, there are concerns around the capabilities of Metaphor to model the available dose response data for the phthalates due to the inability to adequately account for study-to-study potency, heterogeneity, and assess parallelism. The models that are relied upon within Metaphor are linear models and do not have the ability to fit nonlinear sigmoidal shapes, which are necessary to model the dose response data for the individual phthalates. However, the available models in EPA's current BMDS software have models with this capability. The two versions of Metaphor yield almost identical results. EPA followed the methods from NASEM 2017 with some minor differences in methodology, including using a newer version of Metaphor and adding some new data. Incorporating new data should improve the quality of the results. One question is whether there are any differences in dose response between studies of testosterone content and those measuring rate of testosterone production. Also, can EPA address the question of whether different phthalates have parallel dose response curves? While parallel curves are not a requirement for performing a cumulative risk assessment, this might increase confidence in cumulative risk assessments. The modeling approach also provides consistent and robust dose response data, with the approach also facilitating the full use of the full data set of each phthalate, including new studies. Most of the chemicals under consideration have a sufficient data set to exclude one study for sensitivity analyses that can demonstrate the robust estimates of reduced fetal testosterone production. Any departures from the NASEM 2017 approach are explained and justified. The committee identified some uncertainties, including the lack of clear explanation why Metaphor 4.6.0 cannot estimate BMD5s for BBP and DIBP and a BMD10 for BBP. This influenced how the RPFs were derived because BMD40 data was available for all phthalates covered in the assessment. Additional public comments indicate that these BMD estimates can be determined with nonlinear models. It's important to note that previous SACC comments have identified some of these concerns. From the 2023 report, it was indicated that simply selecting a BMR to use for RPF without accounting for dose response parallelism and achieving maximum response will result in highly variable RPFs. And Metaphor cannot test for parallelism, which has been noted in previous SACC and NASEM reports. It was also noted in the NASEM report that its linear regression analysis focused on the dose response relationship, and the models were selected for illustration so they could be easily implemented with existing software at that time, and it was not meant to serve as the basis for risk analysis. One of the public commenters indicated that the NASEM approach is now outdated. That was conducted almost a decade ago, and that Bayesian hierarchical modeling represents the state of the science and addresses the key issues in EPA's modeling and yields RPF values substantially different from the current EPA values. It's critical to refine models and analyses according to current research findings and use the data to test the veracity of the outputs from analyses. As part of the phthalate syndrome, decreased fetal testosterone, testicular testosterone is used as a biomarker of adverse effects and endocrine disruption of synthesis and secretion of testosterone during a critical developmental stage. The analysis and subsequent model generated rely on endpoints and their response, and given that endocrine responses are sometimes nonlinear, an understanding of the endocrinology and utilizing sufficient data to characterize the response becomes essential, especially in the low concentration region. Using BBP as an example, the EPA focuses on a no AL, a low AL approach for the determination of a POD. And while the modeling conducted was consistent, the BMD modeling conducted was consistent with the NASEM approach, in comparing those BMDLs to the no ALs, low ALs, those PODs were suggested to be not as health conservative. However, those no ALs should be compared to BMDs that are consistent with a no AL equivalent as defined by the benchmark dose technical guidance. It's possible that across different phthalates, the PODs from BMD modeling may not be consistent with the identified no ALs, low ALs. However, it does appear that EPA has tried to incorporate this difference in the option 2 of the cumulative risk assessment. Our recommendations are to address the limitations previously identified by the SACC in 2023 and as part of the public comments to demonstrate that the approach is state of the science and able to sufficiently model the available dose response information. And we have a few specifics. One in section 2, can you explain the differences between the two versions of Metaphor and if the application of EPA's BMDS models would provide sufficient and adequate results? And we have a couple of comments around figure legends and things not being documented, which we'll provide in our written responses.
All right. Excellent. Thank you for that summary. And now the associate discussants, Dr. Fox.
Thanks, Dr. Gentry. No further comments.
Dr. Ottinger.
Thank you for that summary. It was excellent. No further comments from me.
Dr. Babbage.
No comments.
And now to the committee. Do we have any comments from the committee? Seeing none, do we, are there any clarifying questions from EPA regarding this response?
Anthony Les with EPA. No questions or need for clarification at this time. Thanks.
All right. So at this point, I need to do a check. Dr. Martinez was having an issue with her her connectivity, and I need to check. Dr. Martinez, are you here with us? Okay. I see Dr. Martinez icon, but I can't hear your own. Oh, there.
I got it fixed. I had to restart my computer. I apologize.
do not worry. This is part of the problem with these kinds of meetings. So, or challenges, I guess I should say, not problem, challenges with these kinds of meetings. So now we're going to turn it back to EPA to read in charge question 5G. And I'm really glad that you were able to join us, Dr. Martinez.
Thank you.
This is Anthony Les with EPA. I'll read charge question 5G. In section 4.3 of the draft non-cancer human health hazard assessment for DBP, EPA has preliminarily selected an HED of 2.1 milligram per kilogram per day, which is a BMDL5 of 9 milligram per kilogram per day, based on decreased fetal testicular testosterone for assessing risks from acute, intermediate, and chronic duration exposure to DBP. The BMDL5 that serves as the basis of the HED was derived through meta-analysis and benchmark dose modeling of fetal testicular testosterone data from 8 studies of DBP with rats, and references are provided there in parentheses. Please comment on the strengths and uncertainties in the selected acute, intermediate / chronic HED for DBP. Thanks.
All right, thank you for getting that into the record. And now Dr. Martinez is our lead discussant.
Right, thank you. So the issue identification, we noticed that a previous SACC committee recommendation for the point of departure for DBP was for using a combination of prenatal and postnatal outcomes, combining data from studies of similar design for benchmark dose modeling of fetal outcomes. And that was from the previous cumulative risk assessment document. And then we discussed the health risk characterization using the HED of 2.1 by the NASM 2017 study, but I think it was just previously discussed very thoroughly, so I'm going to skip that part and go on to a major strength of the use of fetal testicular testosterone is based on its national and international utility by various regulatory agencies, including the U.S. Consumer Product Safety Commission, Australia's NICNAS, and Health Canada. In addition, the utility of the multiple studies to compile this BMDL of 9 milligram per kilogram per day seems on target. The report evaluated the available studies to identify various studies with effects at lower doses below 50 or 100 milligram per kilogram. And 2 studies were identified and reviewed, suggesting the potential for a lower POD, but were set aside due to concerns and limitations. The selection of an HED of 2.1 mg per kilogram per day in the draft non-cancer human health hazard assessment for DBP relies on high-quality research reported in 8 publications. However, it is not clear if the HED may need further refinement and possible reduction based on distinguishing outcomes for altered steroid pathway genes or production of fetal testicular testosterone ex vivo. So the scientific rationale is that the studies on which the HED is based consistently reported decreased testicular testosterone in males exposed prenatally. There were additional studies cited in the draft non-cancer human health hazard assessment for DBP that provide further support for adverse effects on reproductive development and function. As such, the evidence for adverse effects of DBP is consistent in rodents. And the HED of 1.1 mg per kilogram per day set for DEHP was compared to the 2.1 mg per kilogram per day for DBP, suggesting that it is slightly less bioactive as an individual compound. The fetal testicular testosterone data from the studies cited above represent several types of measures. Specifically, several of the papers examined altered gene expression of the steroid synthetic pathways. For example, Johnson et al. 2011 analyzed effects of DBP on molecular mechanisms regulating the steroidogenesis in fetal rat testes. However, Howard Schell et al. 2015 also reported altered expression of mRNAs in the testosterone biosynthesis pathways. So the difference between assay of testosterone content versus ability for the Leydig cells to produce testosterone production is important. Studies by Gray et al. 2021 and Spade et al. 2018 focus on production of testosterone by incubating testes from gestationally exposed males. The media was assayed for testosterone from these exposed male testes from gestational day 21 incubated ex vivo show the decreased concentrations with treatment. The chemical characteristics and data for DBP support the EPA assumption of 100% absorption with oral exposure. There were other adverse effects associated with developmental exposure, including pup mortality, reduced fetal weight, and increased skeletal abnormalities. And that was in the draft non-cancer human health hazard assessment for DBP. These tables capture a suite of adverse effects associated with the gestational exposure and sampling prenatally or postnatally. So recommendations by the committee are they would ask the EPA include studies that were analyzed by NASM 2017 and Gray et al. 2021. And then clarification was requested on section 4.1. We're wondering if EPA only considers studies that supported a lower Lowell. And does that mean that they did not include any doses lower than the 100 milligram per kilogram per day? That was not clear. And the next clarification is we were wanting clarification if EPA considered all non-cancer endpoints or only the male reproductive endpoints. And the last clarification we would like is, was there, and this was mentioned previously, was there any difference in dose response between studies measuring testosterone content and those measuring testosterone production rate? And then finally, there's a couple of typos or editorial comments, and that's what we have for that. That's it. Are there any questions? And did I capture all comments?
Very nice. Thank you for getting that into the record. And then now we can go to our associate discussants, and I've lost, here we go. Our associate discussants, who are Dr. Fox. First one, Dr. Fox.
Nothing to add. Thanks, Dr. Martinez.
Dr. Ottinger.
Likewise, thank you, Dr. Martinez.
Dr. Babbage.
No.
I think I heard him say no comment.
No comments.
All right. And then Dr. Gentry.
Nothing to add. Thank you, Dr. Martinez.
Yes, thank you for getting that into the record so effectively. At this point, we will move to charge question 7, and I believe I'm going to turn this over to Dr. Gentry to lead us through for these questions.
Okay. Did we want to ask EPA if they had any clarifying questions for the previous charge question?
Yes, we did.
Thanks. This is Anthony Loves with EPA. I don't think we have any questions or need for clarification this time. Thank you.
Okay. All right. So I guess we will, if EPA will read in charge question 7A.
Okay, charge question 7. In the draft cancer human health hazard assessment for DEHP, DBP, BBP, DIBP, and DCHP, EPA preliminarily concluded that there is suggestive evidence of carcinogenic potential for BBP, that's in section 4.3.2.4, and DBP in section 4.3.3.3 in rodents based on evidence of pancreatic acinar cell tumors in rats. EPA has further preliminarily concluded that pancreatic acinar cell tumors observed in rats are not appropriate for conducting dose response assessment for human health risk assessment. So part A of charge question 7. Please comment on the strengths and uncertainties of EPA's preliminary cancer classification and rationale for not carrying forward pancreatic acinar cell tumors in rats into dose response assessment for BBP. Thank you.
Okay, thank you. And we will turn it back over to Dr. Martinez as our lead discussant.
Hi, I'm here. Can you hear me okay? And I had to, right there.
Yes.
So I had to close out all my windows and now I have to open up. And if you just give me 1 minute, I'll get there.
That's fine. Take your time.
Okay. Yeah, I restarted my computer and everything closed up.
That happens.
All right, charge question 7A. Get the summary document that's on the shared drive. All right. So the issue identification starts off with the discussion of peroxisomes. And peroxisomes we've had are found in all eukaryotic cells, and they contain oxidative enzymes such as catalase and urate oxidase at such high concentrations that in some cells, the peroxisomes stand out in electron micrographs because of the presence of a crystalloid core. Thus, with any compound that is a peroxisome proliferator activated receptor alpha, PPRA, agonist peroxisomes can increase in any cell tissue, resulting in increased oxidative stress as a byproduct and possibly by organ weight with enough expansion of peroxisome numbers. And we refer to a number of references that the reader can address. And then Health Canada 2024 states that the relevance of the hepatotoxic effects of phthalates observed in rodents is difficult to establish due to species-specific differences in the peroxisome proliferation response, where the rodents are significantly more sensitive than humans to PPAR alpha-mediated induction of peroxisome proliferation. So the scientific rationale is that has this pancreatic acinar cell tumors, the PACs, were only reported has significantly increased for male F344 rats in 2 out of 4 studies from the NTP studies. A dose response is deemed unnecessary and is supported by the lack of response for female rats in both male-female mice, especially since dose response is not apparent for male rats developing pancreas acinas adenoma or carcinoma. And that's from table 415 and table 416. That was from the NTP studies. The NTP characterized results in the same way. And furthermore, the lack of dose response obviates a determination of POD. Instead, the data suggests a threshold effect, especially when reviewing the PACT incidence for BBP, DBP, and DEHP. The PACT arises secondary to PPR alpha agonism and appears to only occur at excessively high doses. Any uncertainties or scientific deficiencies in the data to support the complicated mode of action are not needed to be filled, since the PACT response would not occur without PPRA agonism. The constellation of tumors, regardless of tissue of origin, would be adequately prevented using the non-cancer POD as presented for individual and cumulative risk evaluation. PACTs are related to the PPR alpha agonism. Secondary to liver would not be expected to be present at doses below which there is PPRA agonism. And it refers to the Klonig et al. 2003 reference. While the committee concurs that the PACs observed in rats are not appropriate for conducting dose response assessment for human health risk assessment, there's a divergent view on classification of BBB. So half of the committee disagrees with the classification of suggestive evidence of carcinogenic potential and recommends not likely carcinogenic applicable for those with pancreatic tumors. The PACT MOA is considered and seems reasonable to attribute the lack of PACT response to the decreased PPAR alpha activation for BBP and DBP. And it quotes in the EPA document that the differences in potency for activating hepatic PPAR alpha may account for differences in observed liver tumors, PACs, and Leydig cell tumors across DEHP, DINP, DIDP, BBP, and DBP. So that's the first half of the committee. And the rest of the committee agrees that the agency is correct in its characterization of the carcinogenic potential of BBP. And based on the data available, EPA is correct in, and the rationale includes inconsistent, at best, evidence of tumors across models and weak across the 5 epidemiological studies with exposure to multiple phthalates. This is consistent with the work of the NTP nearly 40 years ago and the IARC in 2000. However, IARC has announced that it will be evaluating 3 phthalates, including BBP, between June of next year. And then the recommendations are that table 414 lists BBP carcinogenicity studies evaluated for BBP, but the committee requests EPA to include the incidence and tumor type of each dose in table 414. Clarification is requested from EPA regarding BBP of what is the value of reporting the positive association between a urinary marker of BBP exposure and cancer mortality. Because phthalates are used in medical devices and saline drug blood bags, that it might be associated with treatment for cancer as well as associated with an exposure prior to cancer. So another committee recommendation is EPA to conduct a dose response assessment or evaluate BBP quantitatively for cancer risk, since any tumor response would only occur at higher doses, and there would be no tumor responses at doses below which there is not PPR alpha agonist response in rodents. And then the last one is, given the limitations and uncertainties, EPA concludes that it is indeterminate evidence of an association between phthalate exposure and subsequent cancer outcomes. The committee recommends that the EPA be more specific and state that there is an association cannot be identified, and that is in line 1, 2, 3, 5. And just to be more specific and saying that the association can't be identified, much less a cause and effect. And then there's just an editorial comment, and that's our comments for 7A.
Okay, thank you very much, Dr. Martinez. We'll go to the associate discussants, Dr. David.
No additional comments. Thank you.
Okay, Dr. Wolf.
No additional comments. Thanks.
Okay, Dr. Heiger Bernays. Looks like she's online. But I guess we'll come back. Dr. Babbage. Okay, I guess we'll open it up to the rest of the committee.
Yeah.
Oh. Dr. Babbage, are you trying to respond?
While he's trying to respond, can I ask a quick question?
No comments from Mike Babbage.
Okay.
Can you remind me, so like half the committee had one opinion and the other half of the committee had a separate opinion. Are we supposed to get to a majority?
No,
Okay.
we do not have to reach consensus. And I think that was part of the discussion yesterday for one of the questions is documenting those differences of opinion.
All right. Thank
Dr.
you.
Cobb, Dr. Kamal, anything to add on that?
I agree with you. We try to find places where we have clear majorities so that we can write recommendations. There are a lot of times where we don't get consensus. And so sometimes a recommendation has to be either omitted or say that we can't make a recommendation because we're split on the two different versions. Or
Yes.
two different perspectives.
Yes, what Dr. Cobb and Dr. Gentry mentioned is correct. However, if you would like to have a breakout room with the discussants and further discuss to see what the differences were and maybe we can reach consensus, then we can do that. We will have time today during lunch, or we can arrange for any other time.
I would also offer that as long as we don't exceed quorum,
yeah,
we can have people who would like to join that session to have input speak into that. And people can send you their perspectives. Any committee member can send you, as the lead, their perspectives that might change your tally one way or the other, as long as there's a justified reason for sending you that perspective.
Okay. All right. Anybody else with questions or comments? Okay, I'm not seeing any hands. I guess I'll ask EPA if they have any clarifying questions.
Hey, this is Anthony Lez with EPA. I have one clarifying question. I thought I heard maybe two slightly conflicting things from the committee in that response. It sounded like the committee concurred with the EPA's decision not to carry the PACs forward for dose response assessments. I believe that's what Dr. Martinez said kind of earlier in her response. But then when she was talking about recommendations to the agency, I thought she had recommended that we conduct dose response assessment for cancer outcomes. Can you just clarify that? I might have misheard though. Thank you.
Hi, yes, that it was a committee recommendation, and I think it's because half of the committee had one view and the rest of the committee had another perspective. And I think that would be helpful for us to discuss that at a breakout and see if that really is a recommendation. So you're absolutely correct. And I will
Okay.
request a breakout room for that today.
Okay. All right. EPA, anything else for clarification?
Yeah, I guess I'd just like to, put on the record that, if the committee's in agreement that, we carry forward that suggestive evidence classification, the cancer guidelines don't recommend dose response assessment or carrying that forward to risk characterization. So just like to put that on the record.
Okay. Okay. Anything else related to this charge question? Okay, if not, I guess we will move to charge question 7B.
All right, this is Anthony Luz with EPA. So charge question 7B. Please comment on the strengths and uncertainties of EPA's preliminary cancer classification and rationale for not carrying forward pancreatic acinar cell tumors in rats into dose response assessment for DBP. Thank you.
All right, thank you. And I will turn it over to Dr. Wolf as our lead discussant.
There we go. So these two were very similar, and rather than repeat all the same text, the discussion around peroxisomes found in all eukaryotic cells with their associated references will be in this section as well. The response about Health Canada, the relevance of the hepatotoxic effects of phthalates observed in rodents is difficult to establish due to species specific differences in the peroxisome proliferation response with the references, and those will be in there. The pancreatic tumors arise secondary to PPAR alpha agonism and appear to only occur at excessively high doses, as Dr. Martinez stated as well. So a lot of this is just a different chemical, same effect. Pancreatic acinar tumors are related to the PPAR alpha agonism secondary to the liver and would not be expected to be present at doses below which there is no PPAR alpha agonism. And that's there's references for that as well. Some committee members did agree with the agency of its characterization of the carcinogenic potential of BVP. The NTP characterized the results in the same way. Furthermore, the lack of dose response obviates the determination of point of departure. Instead, the data suggests a threshold effect, especially when reviewing the packed incidence for BVP, DBP, and DEHP. And there's references for that as well. The rationale includes inconsistent at best evidence of tumors across models and weak across the 5 epidemiologic studies, in that there was exposure to multiple phthalates. In the data that suggests limited evidence of genotoxicity for DBP in some in vitro assays, is that associated with high dose oxidative stress? If so, then that would also be a threshold response. For example, the mouse lymphoma assay, are the positive responses secondary to high concentration induced oxidative stress within the assay, leading to an effect that still would have a concentration response and likely also a threshold. Given the limitations, so to quote the document, given the limitations and uncertainties, EPA concludes that there is indeterminate evidence of an association between phthalate exposure and subsequent cancer outcomes. The language is a bit squishy, and the committee suggests that why not be more specific and just make a statement that an association cannot be identified, much less cause and effect. in section 4.4.1.1.5 regarding the uncertainties, the agency states, regardless, the possibility remains that mechanisms other than PPAR alpha may play a role in the observed PACs in Leydig cell tumors in rats, such as activation of other nuclear receptors or cytotoxicity and regenerative proliferation. There should be data for this. So if cytotoxicity and regenerative proliferation did occur, it would have been obvious in the shorter term studies in the testicle and pancreas. Also, this response would, if it did occur, would be a high dose effect. So doses greater than what is typically necessary for PPAR alpha activation. These have been reported in studies, and so very high doses with excessive above the MTD, you can see cytotoxicity, regenerative proliferation in the liver, but these are doses far above what you typically see PPAR alpha agonism, and those are secondary toxicity effects, and those have been reported as well. EPA has preliminary concluded there is suggestive evidence of carcinogenic potential of DBP in rodents, and consistent with the cancer guidelines of 2005, did not conduct a dose response assessment or evaluate DBP quantitatively for cancer risk. Some of the committee members did suggest that since any tumor response would only occur at doses above PPAR alpha agonism, why not say, like the other phthalates, that it's not likely to be tumorigenic above PPAR alpha agonism, or just not likely to be tumorigenic based on this threshold response. So I do have to reformat the proper uncertainties and recommendations, but that's summarized what we had discussed. And I turn it over to the other committee members.
All right. Thank you, Dr. Wolf. Dr. David.
Actually, I do have something to add to this discussion, which regrettably I didn't send to Dr. Wolf or Dr. Martinez, but I will. And if one goes back to the original NTP study of DEHP that was finalized in 1978, they did see pancreatic acinar cell tumors, but the incidence was not statistically different. And that begs the question, has the strain changed over the years such that there is some greater susceptibility to that particular tumor type? So that's something that probably Dr. Wolf can speak to better than I, but it's an interesting observation. Thank you.
So I think in 2000, maybe it was a little bit later, NTP did, now it's called DTT, NTP did change the strain of rats. So it went from Fisher 344 to the Sprague. And so they would definitely have different background incidences of the different tumors. I don't recall if they've run any phthalates since the new strain. I'd have to look at that, but that's a good point, Dr. David.
Okay. Dr. Martinez.
No, I don't have anything to add. I think he captured it very well. Thank you.
Okay. Dr. Heiger-Bernays, are you with us?
I am with us. I wasn't with us. I've been having internet issues. So, okay. Yes, I think everything was read that I had contributed. I'm intrigued by this last little bit of conversation with regard to strain, right? Because that's so critical. And I don't know whether Dr. David is putting that into the record or leaving it out, or whether that was just, I don't know. And if so, I suspect that we'll need to comment on or provide context for the change in strain and background tumorigenesis. But as read, you've captured everything. Thank you.
Okay. Were you able to hear
No,
7A?
no.
Okay.
So I have a plan. My
Okay.
plan is to review the summary statement, and then when Dr. Kamel makes the recording available for today, I'll listen to that if
Okay.
that works.
Yes, please
I
make sure you're.
apologize.
Oh, no problem. I think we're all having our episodes of connectivity and things like that, but as long as we make sure your comments are captured.
Okay, thank you.
Dr. Cobb?
I was just going to say there was also, Wendy, there was also a breakout room assigned for today for your group. So there's a chance to get some of that information during that
Oh,
meeting. Perhaps.
okay. All right. Thank you.
Okay. Any other comments from the committee on this question?
Yeah, so just to further, because this came up at the last phthalate discussion on mononuclear cell leukemia, but in 2006, the NTP decided to switch to different rat stock due to a large incidence of certain background tumors, including Leydig cell tumors. And so there's references on that change and switch. And so the pattern of tumor response is different in the Spragues and in the Fishers, and that's why they changed the background strain. But that was 2006.
Okay. All right. Anything else from the committee? Okay. EPA, do you have any clarifying questions? You're on mute.
Sorry about that. This is Anthony Les with EPA. No questions at this time. Thanks.
Okay. Thank you. Okay, I guess we will move on to charge question 8A.
Hi, this is Greg. That's me. All right.
Wait, we have to let EPA read the question
Oh,
into
okay.
the record.
Okay. This is Anthony Les with EPA, and I read charge question 8. So as discussed in section 5 of the draft cancer human health hazard assessment for DEHP, DBP, BBP, DIBP, and DCHP, no chronic toxicity or cancer bioassays of experimental animal models are reasonably available for DIBP or DCHP. Therefore, EPA used elements of the Rethinking Chronic Toxicity and Carcinogenicity Assessment for Agrochemicals Project, RECAP, Weight of Evidence Framework, with references provided by Hilton et al. 2022 and OECD 2024, as an organizational tool to evaluate the extent to which the lack of carcinogenicity studies impart significant uncertainty on the human health risk assessments for DIBP and DCHP. Human health hazards and toxicokinetic properties of DIBP and DCHP were evaluated and compared to DEHP, BBP, DBP, DINP, and DIDP, also referred to as read-across phthalates. So charge question 8, part A. Please comment on the strengths and uncertainties of EPA's application of the RECAP framework. Thank you.
Okay, thank you. And Dr. Rowlands, now it's time to turn it over to you.
Thank you. Okay, so the strengths regarding this question, very lengthy question, is the recap was developed by expert stakeholders from academia, industry, NGOs, and government. And when developing the framework, the decisions were constantly checked with government practitioners to ensure the output and conclusions were relevant to risk assessment by agency decision makers. The RECAP framework was an appropriate method of organizing much of the information and lines of evidence to evaluate DIBP and DCHP. Because EPA is applying a new framework for this toxic assessment adapted from RECAP for this read-across weight of evidence analysis, a rationale for selecting this framework is necessary. The most recent SACC review of a read-across approach was for 1,1 and 1,2 dichloroethane, DCA, in the DCA risk evaluation and related documents. A different read-across approach framework was referenced. Lizarraga et al. 2019. All the references are provided. I will not read them out completely. And the SACC recommended incorporating the work of Lizarraga et al. 2023. So the recommendation here is please explain the selection of the adapted RECAP framework, including its advantages and disadvantages compared to the Lizarraga et al. 2023 publication read-across framework. An easy to read and concise method for presenting and evaluating data, including phys-chem properties, acute toxicity, development reprotoxicity, mode of action, and chronic and carcinogenicity information from other phthalates, the read-across chemicals. This is summarized in Hilton et al. 2022, provided clear guidance on what should be included to result in a transparent structure. And the commenter found the agency document to be a good example based on supplements 1 and 2 of the Hilton publication. The group size, similarity, and quality and consistency of data are strong and can be used to predict the toxicity of DIBP and DCHP. The agency did an excellent job in following the suggested approach of Hilton et al. Paper, as well as the framework published as an OECD Integrated Approaches to Testing and Assessment, or IATA. The agency may, IATA, the agency may wish to present the findings using the Risk 21 framework approach, as it is a very useful decision support and communication tool. Another example of the application of the RECAP and OECD IATA framework has been published and might be useful for additional reference for page 96, line 2912. That's Getz et al. 2024. This paper presents additional examples of the application of the framework. In section 5.6, the agency titles it Evidence of Immune System Perturbation. Regarding the relationship of the immune system, aside from lymphocytic tumors, it is specifically immune suppression that is considered procarcinogenic in humans, where there is a loss of immune surveillance of transformed cells, and it's summarized in Cohen et al. 2019. Okay, now turn our attention to uncertainty. On page 106, line 3141 to 3142, as discussed in section 3.3, DBP was positive for mutagenic activity in several in vitro mouse lymphoma assays. However, DBP showed no mutagenic activity in other in vitro bacterial reverse mutation assays. This evaluation needs further scrutiny. Were the assays positive at high concentrations only, and would they be concentrations that are cytotoxic and cause oxidative stress in the mouse lymphoma assay system? Overall, this is a high-quality report due to its succinct summary of the toxicity and epi data. However, a summary of the structural similarity measures, such as Tanimoto scores or dye similarity index, should also be included with a description of the chemical functional groups and/or structural alerts. This title is misleading since the technical report document summarizes the genotoxicity in cancer, L492, hazards associated with DEHP, BBP, BBP, DBP, DIBP, DCHP, DIMP, and DIDP, as opposed to the title listing only DEHP, BBP, DBP, BBP, DBP, DIBP, and DCHP. Use of the term read across is repeatedly used and not in the correct manner. Read across is a method and in this case is conducted using DIBP and DCHP as analogs for surrogates. Okay, recap includes data from reach across, NAMs, and computer modeling. As such, it is very important to utilize frameworks that address how these types of data are reliable and relevant, including the uncertainties for each approach. In the draft Cancer Human Health Hazard Assessment for di-2-ethyl phthalate, DHP, DBP, BBP, DIBP, and DCHP, page 96, lines 2914 through 2926, the agency outlines the elements of the recap framework that were used. Please explain which elements were not used and why, and the rest of the reference. So I'm done.
Okay. Thank you, Dr. Rowlands. See if we have any additional comments from the other discussants. Dr. Wolf?
Yeah, this is Doug Wolf. Full disclosure, I was a co-author on the recap publication as well as the OECD IATA project. I do want to say I really appreciate the agency making this very excellent effort in using them, and I think it's a big step forward. So congratulations to the agency on this activity.
Okay, thank you. Dr. Martinez?
Hi, no, I think you covered it very clearly and listed all my comments. Thank you.
Okay, Ms. Jenkins?
No additional comments. Thank you.
Okay, Dr. Fox?
Hi, yes. So I just add that as we're going through the questions, I'm having sort of bigger picture thoughts about kind of transparency and consistency, and kind of thinking about the previous work of the SACC and sort of using new methodologies, or sort of keeping up to date, and but not like sort of changing every time we do a different one. And I realize that we have to balance sort of the transparency and consistency with, keeping up to date. But I started just a kind of general context for some of my concerns about sort of using the recap framework when we just used a different one for the last assessment that we looked at. That's all. Thanks.
Okay, thank you. Anyone else from the committee? Okay, not seeing, oh, Dr. Heiger-Bernays.
Yes, thank you. I want to support Dr. Fox, the comment that Dr. Fox made. It's great that we're evolving and using different tools, but at some point we need to have both the transparency and the consistency so that the SACC and reviewers and whoever is using this isn't constantly trying to figure out what's next and how to walk through these evaluations so there is internal consistency. And so thank you, Dr. Fox, for bringing that up.
Okay, Dr. Cobb.
Without getting into the weeds of report writing and such, perhaps a few sentences that explain exactly what Dr. Fox and Dr. Heiger-Bernays are saying is that we have recommended other things, but now that the recap is starting to become more well understood, let me say that this transition is occurring, and we don't want to confuse people by that. And I think that would solve the problem. And that's all really I had to say.
Okay. Dr. Wolf.
Yeah, I appreciate the concern around thoughtfully moving forward. But the other thing to remember is in the space of new approach methodologies, which the recap fits into, as well as the OECD IATA program, it's moving pretty rapidly. And so, again, I think it's really, really important that this example that the agencies put together, and I hope they pull it out and publish it as a standalone publication to move things forward. Other activities are going along, bigger read across, lots of different kinds of new approach methods. We've talked about transcriptomics point of departure with the aquatic species. First time I've seen that applied. So there's this is hard because the speed of these changes is going very fast. And so having these opportunities to test them out and have panels like this review them and make suggestions is going to be really important. And I think we're going to probably be seeing more and more of these different kinds of frameworks and different approaches in the upcoming documents as they get prepared. And all I can suggest everybody is hold on.
Good point. Good point. Thank you. Anybody else from the committee?
Hi, I have one more comment like along the lines because they did read across and I've been doing read across quite a bit and it seems like they have a new kind of methodology of how they're doing their read across and I guess the language is a little bit different and I think there should be more consistency in the read across, just how they're collectively using it and following like the OECD and the other EPA and other international read across methodologies.
Okay. Dr. Fox?
Yeah, so I guess I would just add that we always, we need to remember why we do risk evaluations, right? I guess always want to make sure we remember that context, and yes, using new tools when they make sense. I think that the gist of my comments was since a different approach had just been used, right, in a very recent assessment, can the differences at least be explained? And the advantages and disadvantages, whatever, made clear. Thanks.
Okay. Dr. Wolf?
Yeah, I think Dr. Martinez's point is right on point because she has been doing read across. OECD just came out with their document on their approach to read across. And so that's how fast these things are changing as well. Yeah, we do need to refer to the OECD read across documentation, but that wasn't available 2 and 3 years ago when we were doing the recap project. So that's happening very fast. I think Dr. Fox is just as an aside, perhaps as another SACC activity or SAB activity, the agency might want to take a look at some of these different tools that they're putting together and have a discussion around best practice on these new approaches and tools to start incorporating them consistently.
Okay. Right. Anyone else from the committee? Okay. EPA, do you have any clarifying questions?
Anthony Lowe's with EPA. We don't have any clarifying questions. Thank you.
All right. I guess we're ready to move on to charge question 8B.
Okay, charge question 8B. Please comment on EPA's preliminary conclusion that the lack of chronic toxicity and carcinogenicity studies are not a significant source of remaining scientific uncertainty in the qualitative and quantitative risk characterization for DIBP and DCHP. Thank you.
Okay, thank you. And I will turn it over to Ms. Jenkins as our lead discussant.
Thank you. This will be fairly short. The discussants agreed that the agency did a thorough job on this activity. Specifically, Section 5.10 was characterized as excellent and impressive by a discussant, and discussants applauded the agency in using a combined approach to protect against all forms of chronic toxicity, including carcinogenicity. That's in Section 5.9. Discussants agreed that the lack of chronic toxicity and carcinogenicity studies is often addressed by the weight of evidence from read-across, subchronic, subacute, and genotoxic, as well as other studies. The weight of evidence from combining the results from these studies can inform the likelihood of chronic toxicity and carcinogenesis. One discussant agreed with the agency's conclusion that DEHP and DINP are not likely to be carcinogenic to humans, but instead refers the agency to the Quantick et al. 1983 study. That study concluded that they are unlikely to cause cancer in humans because the mode of action does not occur in humans, and not that they are threshold carcinogens. The discussant also points out statements referring to the points of departure protective against carcinogenicity, and those are moot in light of the MOA of these phthalates. I was going to also add that one discussant had a number of comments that were better, more specific comments that really applied to question 8A. And so I forwarded those to the lead discussant for 8A. And that concludes our comments on 8B. Thank you.
All right, thank you. Let's go to the other discussants. Dr. Rowlands.
No further comments.
Okay, Dr. Wolf.
Just to underline how great what the agency doesn't get enough credit when they do things that are exemplary, and I think they did just a terrific job on particularly on this part of the activity. So I want to thank them for being so forward thinking on this.
Okay. Thank you. Dr. Babbage.
I just pose a question. The part of the paragraph about the cancer mode of action, I'm wondering if we can just leave that to question 6. I'm not sure it needs to be here, but I'll leave that to the lead discussant.
Ms. Jenkins, do you have any thoughts? Go ahead.
Yeah, I have that in my comments that it may be better in 6A, 6B. So yeah, I agree. We'll see, I guess, how that turns out, and then we can coordinate with those groups. Thank you.
Okay. I think it might be good if everyone would like if we take a short break. I know that we are planning for breakout sessions over lunch. So I will turn to Dr. Cobb and Dr. Kamal for thoughts on this and possibly giving everyone a break since we're running so far ahead.
I think a break is good, and I would also ask everyone on the committee to check an email I sent 10 to 15 minutes before this session starts about having some summary slides pulled together for each charge question. But let's not have that dialogue while we're trying to have our meeting. Just look at that email and maybe respond.
So the break is a good idea. Yeah, it's always good to have breaks. So we can have like a 15-minute break. Is that good?
Sounds good to me.
All right.
Welcome back, everyone. Hope everyone had a good break. Before we get started, Dr. Kamal, is there anything administrative we need to take care of?
I just wanted to take care of the breakout rooms and confirm who will go to which breakout rooms. So as far as I understood right now that Dr. Chasen wants a breakout room. Is this for charge questions 9 to 12, the cumulative risk assessment session? Dr. Chasen?
It's for 11A, B, and 12.
11, AB, and 12. Okay. And those who will be in this breakout room are Dr. Stephanie Ike, Mary Fox, Lee, Dr. Cheng, Doug Wolf, Dr. Ray David, Eleanor Fanning, Dr. Janelle Martinez, Daniel Spade, and
Mike Babbage.
Mike Babbage. Okay, and Mike Babbage. All right. Of course, Dr. Cobb and Dr. Gentry, if they would like to join, they can also join. So this is one room. I have another room for Dr. Martinez, and the names from what I understood also would be Dr. Ray David. Now, if we have the same person in different rooms, I don't know how we're going to work that out, but we'll see. Ray David, Dr. Douglas Wolf, Wendy Hyger Bernays, Dr. Gentry, Dr. Mike Babbage, and Dr. Dan Spade. And it looks like most of them are in both rooms, so we must have them at separate times. So that we would suggest to have 2 45-minute breakout rooms. So we will start with Dr. Chasen's breakout room right at the time of lunch. And then after that, we will follow with Dr. Martinez's group for the 45 minutes after. Now, if Dr. Chasen finishes earlier, we can arrange for that. If she needs more time, we can also arrange for that. We have plenty of time, so please take your time during these discussions. Now, I know.
Doctor,
yes.
Come out. If we do finish, should we send you an email? What
Sure.
should we do to flag? Just send you an email or something?
Sure, and I mean, one of our group will also be with you in the room, and they will know and let us know.
Oh, okay. Thank you.
You're welcome. I believe also, Dr. Ottinger, did you want a breakout room today, or did you mean this for another day?
Let's wait with that because I think it's more important to have folks meet about the upcoming questions, and we'll circle back to the earlier charge questions later. Thank you.
Okay, you're welcome. So are there any other requests for breakout rooms for today? Right, looks that we're good for these breakout rooms. So from now, we are seeing that our lunch break will be for about 1.5 hours, except for those who are going to be in the breakout rooms. Sorry for that. But anyway, we can continue now, and I'll hand it over to Dr. Gentry.
Okay, are we still scheduling lunch for 12:30?
Sure. Yeah.
Okay.
Yeah, I guess so. 12:30 would be okay.
Okay, we'll see if we can get to 9 and 10, because I think the breakout is around question 11, right, Dr. Chasen?
That's correct. And that the conversations are basically the same for 11, AB, and 12. So depending upon what the group decides, it's probably going to need a little tinkering with the public comments that come out of that, those two particular conversations, okay? So I was looking at this last night, Dr. Gentry, and wondering if we get bumped up against, if we don't, or if we aren't able to coherently put together our recommendations, is it possible to skip and go to 13, et cetera, because that's a different topic. I don't know whether that's an alternative, but that would give 11, A, B, and 12 time to rewrite if necessary and then collaborate so we don't accidentally get confusing replies. Is that possible?
I think, and I will defer to Dr. Cobb and Dr. Kamal, but go ahead, George.
No, please go ahead and state your preference.
Well, I was just going to say that I think we've checked with the lead discussants on the dermal exposure section, which is questions 13 and 14. And I think they're ready for today. Correct me if I'm wrong. So,
you're correct, Cynthia.
Okay. So I think we could cover 9 and 10, and skip to 13 if we need to today.
That would be great. I appreciate that. Thank you.
Yeah, and I think we can, I tend to agree with that, Dr. Gentry. I will say that 15, I think there's an indication 15 is absolutely not ready today at all. And 12, there may want to wait towards the end of the day. So maybe this gets us aligned
George,
with that.
12 is part of that package, 11A, B,
Hi.
and 12.
Dr. Fanning?
I can address 12. I'm the lead discussant on 12. What I plan to do on that one is to check in with discussants during the lunchtime breakout, and we will decide during that meeting whether discussants are comfortable with reading in what we have today. If we are not at some reasonable level of consensus during the breakout, I would like to then propose that I communicate to our co-chairs that it would be preferable to wait for tomorrow afternoon. So I think we can get back to you right after lunch as to our level of preparation on question 12.
Okay.
Sure. And I also want to say that we can also have a chance to have more breakout rooms this afternoon, maybe like 3 o'clock or 3:30, around that time, if we need to. And then we reconvene and continue our discussions. So it depends how it will go. So we'll see how it's flowing, and then we're going to decide from there.
Okay. I think Dr. Martinez, you have a question?
Not a question, but I was going to say, I think 11 and 12 is a longer discussion, and I think 7 would be sufficient with the 30-minute and give them the extra 15 minutes, if that's okay. Thank you.
Okay. Dr. Cobb?
Well, my computer stopped responding, but I'm here, much to everyone's chagrin. I agree with Dr. Kamal's comment that we can certainly have breakout groups mid-afternoon if we need to. When we have our normal break time, we can take an extended break then. I think that's an excellent idea. The other thing I'll just kind of get on the table is that email I mentioned before was whether or not we should have summary recommendation slides at the conclusion of the entire meeting, so that we, as part of this meeting, each charge question provides a summary of charge question recommendations, so that it's on the record as slides, and that'll give EPA a little bit of a head start on responding to the essential recommendations, not each and every fine detail recommendation, but the essential recommendations that are going to come out of this report. So I think I think that's kind of seeming like it's going to be essential based on the fact we may be still working on what those recommendations are going to look like at real time today or even tomorrow.
I guess I would just add that as long as we caveat those as our kind of pre-meeting draft recommendations or post-meeting draft recommendations, I think there's going to be work to do. I know some of the groups I'm working with are trying to deal with the public written and oral comments and other things that are coming up during the meeting. So I just want it to be clear that whatever summary we provide, it's the overarching recommendations we have at this point, but there could be other things come up in the final review and writing.
Absolutely.
Dr. Rowlands.
Thank you. So Dr. Cobb, I just want to make sure that I understand this. Basically, what you're wanting are the recommendations, and that tends to fall under the uncertainty sort of questions that we address. And you know, the good stuff, fine, no changes, but it's the stuff we think is uncertain that needs to be laid out. Is that what you're asking for on a slide?
Basically, what the things that your response says, these are the recommendations, the committee recommends that, those particular items.
Okay.
And they can be uncertainties, or they can be just I think the uncertainties, you're right. That's probably the best example of that.
Yeah, well, thank you, because I agree. That's where we came out with things that need to be done. Those are our recommendations. So we can do that. That's not a problem. If you really want it, we'll do it. But that's where I'm going to focus if I have to do this.
Okay, Dr. Fanning?
Yeah, I just want to support a little bit what Dr. Gentry raised about concerns. I wouldn't want to see us committing to exactly the language of recommendations that we put on a slide on Friday. I think that we need the time. I think that they need to be expressed as proposed recommendations. I think it would be very helpful if our chairs made that very clear for the public record that these are proposed, and the committee still has some editorial time to proceed on them. I just don't want us to hurry and get kind of locked into language that it turns out a discussant or another who hasn't had time to weigh in is then unhappy with. So let's, I'm on board with the idea. I just want to clarify that they should be proposed at that time and not characterized as final.
I agree. Dr. Chasen?
I don't understand what this adds to EPA's understanding of our points. I mean, they're present for these discussions. We've read our entire thinking into the record with very clear lists of recommendations. And in addition to adding another level of work here, I think there's some peril in having the committee present, somehow prioritizing their words without review and I in a rushed way at the end of this, that it could be misconstrued. And I don't see what is so beneficial here that EPA can't gather from these 5 days of conversations that makes it worth this kind of risk of misinterpretation or omissions or whatever. So I'm I just not probably on board with this. Of course, if it's required, I'll do it, but I think this should be reconsidered.
Any additional thoughts or comments from anyone on the committee? I see your point, Dr. Chasen, as well, and that's why I was trying to clarify this is something initial or drafty. I don't think it's in any way we should indicate it's suggests some type of priority. It's more of a summary of what we've discussed and heard during the meeting. And it breaks it down into something short, EPA could have, but it doesn't mean it's anything final or, I mean, we've got work to do. That this is a lot of material, and anything we put together cannot be anything considered as our final priorities or recommendations.
But EPA already has YouTube. It has, I mean, unbelievable amounts of stuff. Each of those people can go back, and I think our conclusions and recommendations are crystal clear in the conversation, especially in some of just the discussions where they can pick up what is needed in terms of clarifications, et cetera, which in many cases are just as important as the very distinct recommendations that we list. So I just think that this is just dangerous, that somebody's going to misconstrue or just quote these and not our report. And we already have issues about the use of our reports. So I just think this is adding another level of concern.
Okay, so very good points. Dr. Heiger-Bernays?
Yeah, thank you. I agree with Dr. Gentry and actually Dr. Chasen that I think we're all exhausted, honestly. Having gone through this and trying to keep everything straight, I'm concerned about then summarizing sort of each of the questions, unless these are very high level summaries, but I don't know. I could be convinced, but honestly, I'm struggling with spending more time. If the group feels that's efficient and useful, I'll do my best. But I think we still have a lot to work through in the remaining charge questions and the big picture, the integration, which isn't really a question, but it's still something we should be able to think about. So thank you.
Dr. Graham?
Hi, I did not agree with doing a summary of our responses, but I think that if we just copy and paste the recommendations that we have in our comments as of the end of the meeting and put that on a slide, I can see where that gives EPA 60 days prior working time to start working on some of the recommendations. So I'm not sure if Dr. Cobb and Dr. Gentry are suggesting a summary of our responses or just the recommendations, but I would agree with the recommendations.
Dr. Cobb?
So really quick, I had in my email asked folks to respond and I didn't get a response. That's why for many people, that's why I brought this up. And I suggested that if we need to, we could discuss this in an administrative group right after this meeting, so we didn't have to take this time to discuss during the public meeting. And to Dr. Graham's point, that it was simply, what are your recommendations that you can agree on now that can go into the into a slide that that would give EPA a little bit more lead time on some of the things that we certainly are going to be recommending. And I'm not suggesting this in a vacuum. We have done this in the past when we had a significant number of charge questions with many, many recommendations to give EPA some lead time on responding to those charge questions. But I hear what people are saying about time constraints and mental energy expenditure. So perhaps this is not the best idea, but we can maybe discuss this right after the meeting today. Thank you.
Okay. All right. We will take that into discussion later today. I guess at this point, unless there's anything else we need to discuss, we will resume the charge questions. Dr. Kamal, we good with that?
Yes, please.
All right. I think we are on charge question 9. So if EPA would like to read that one into the record.
Sure. This is Anthony Luz with EPA, reading charge question 9. In section 2.3 of the revised draft technical support document for the cumulative risk analysis of DEHP, DBP, BBP, DIBP, DCHP, and DIMP under the Toxic Substances Control Act, TSCA, EPA preliminarily selected DBP to serve as the index chemical because it has a high-quality toxicological database demonstrating effects on the developing male reproductive system consistent with the disruption of androgen action and phthalate syndrome. It is well characterized for the MOA associated with phthalate syndrome and has the most fetal testicular testosterone dose response data in the low-end range of the dose response curve, where the BMD and BMDL estimates at the 5 and 10% response level are derived. Please comment on the strengths and uncertainties of the selection of DBP as the index chemical. Thank you.
Okay, thank you. And I will turn it over to Dr. Babich as our lead discussant.
Okay, so the committee agreed that it's reasonable. We agree with EPA that it's reasonable to use dibutyl phthalate as the index chemical, as stated by EPA. The index chemical should meet certain conditions, like having a high quality database, dose response data, and representative of the type of toxicity of the group and the class, and a well-characterized mode of action, adequate dose response data are available for both dibutyl and DEHP. However, DBP has more data in the low dose range, which is what really clinches its selection as the index chemical. In contrast to DEHP, there are 3 studies with doses as low as 1 milligram per kilogram per day. This is important because it reduces uncertainty in the low dose range. And furthermore, EPA showed that the relative potency factors are highly consistent no matter which point of departure they're based on. The BMD benchmark dose 5, 10, or 40. I think that's an important point. As far as uncertainties go, we didn't have very many. The assumption that phthalates under review have sufficient data to assess any adverse outcome may be weak, mainly because there were only studies in rats identified for butylbenzyl dicyclohexyl and diisononyl phthalate. So any conclusions about the potency in other species will be determined based on DEHP and DBP. the other uncertainty is the agency didn't present benchmark doses for the standard deviation method. That is, be it a benchmark response set at one standard deviation from the control group mean. This is for studies on testosterone production rate, which is a continuous variable. This is recommended in EPA's benchmark dose technical guidance from 2012 as a, quote, standardized analysis for comparison purposes. However, the extensive database for phthalates provides adequate biological and empirical understanding for the selection of BMRs used in the individual phthalate technical support documents, as well as the cumulative risk analysis. And that's our summary of comments on charge question 9.
Okay, thank you. We'll go to the other discussants. Dr. Merced Nieves.
Thank you, Dr. Babbage, for the summary. I have nothing to add.
Okay. Dr. Spade.
My comments were captured. I have nothing to add.
Okay. Dr. Fox.
Yeah, nothing to add. Thanks, Dr. Babbage.
Okay, and Dr. Wolf.
Two things. There were other comments in here, but I think most of them are specific to different sections of the, but they'll be reflected in the write-up, I presume, even though they weren't discussed, spoken out here. The other thing I would like to just enhance a bit, there's the assumption that all phthalates under review have sufficient data to address any adverse outcome may be weak. I think, at this stage, we don't really need to list every possible ISID that you could possibly see at any dose. I think the question is, will the agency be confident with the final points of departure and the risk assessments or in the reference dose that they would be protective for any possible ISID? If you think something would happen at a dose below that, then that would be a concern, but their approach and processes, I think, should protect against any adverse outcome, whether you have mouse studies or rabbit studies or deficient in all those studies. Thanks.
Okay, thank you. Dr. Babbage?
Yes, I forgot to scroll down a little bit farther. So my comment or my question for EPA was, were there any differences in the dose response between testosterone content as compared to testosterone production rate?
Okay. Dr. Chasen?
Thank you. I'd like to thank Dr. Wolf for his comment, because I think that is sort of a guidepost for us as we consider the conversations over 11 and 12, and to sometimes we go down a wormhole, if you will, and can't find our way back to the surface. And I think that Dr. Wolf's clarification of what's the real purpose of these hazard metrics. And so I would just like to say that I think that that's an important concept for us all to keep in mind as we're looking at the math in these various pieces. Thank you.
Thank you. Dr. Ottinger?
Just reinforcing the last comment by the lead, and that is that if there's distinguishing between production and release of testosterone, meaning from the ex vivo versus the content or concentrations, it would be helpful to distinguish that for the various chemicals. And I don't know if that's been done or if that's what was intended by the comment. Thanks.
Okay, thank you. Anybody else from the committee? Okay, seeing no hands up, I will ask the EPA if they have any clarifying questions.
Anthony, with the EPA. We don't have any questions. Thank you.
All right. I guess we will now move on to charge question 10. The EPA wants to read that into the record.
Sure. Okay, so charge question 10 is described in section 2.4 of the revised draft technical support document for the cumulative risk analysis of DEHP, DBP, BBP, DIBP, DCHP, and DINP under the Toxic Substances Control Act, TSCA. For input into the draft CRA of phthalates under TSCA, EPA has preliminarily selected relative potency factors, RPFs, calculated using BMD 40 estimates based on reduced fetal testicular testosterone content and/or production. Please comment on the strengths and uncertainties of the derived RPFs. Thank you.
Okay, thank you. I will turn it over to Dr. Spade as our lead discussant.
Okay, thank you. Can you hear me?
Yes.
Okay, great. So I want to start with the caveat that we had a draft response for this question that has changed as a result of discussion last night and this morning. So I've made an attempt here to capture all of the thoughts of the charge group, but I will encourage the other discussants to speak up if I miss anything. To develop a cumulative risk analysis for a group of chemicals with similar characteristics, EPA utilizes relative potency factors, or RPFs. The agency used BMD 40 for decreased fetal testicular testosterone to derive the RPFs for the different phthalates while using DBP as the index chemical. The committee noted several strengths to this approach. First, the process for estimating benchmark doses is robust in that it considers data from multiple studies. First, concordance between the RPFs calculated based on BMD 5, BMD 10, and BMD 40 for DEHP, DCHP, and DINP, and based on BMD 10 and BMD 40 for DIBP. That concordance contributes some confidence that the dose response curves are likely to be sufficiently parallel for DIBP and BBP, where BMD 5 and/or BMD 10 could not be estimated. The committee found that this largely addressed the concern about the shape of the dose response curves previously expressed by the SACC. Second, the RPF values across the phthalates under review are consistent with the likely metabolic products, i.e. monoesters that trigger the first key event in the MOA. DIBP is hydrolyzed to monoisobutyl phthalate, which is close to but not quite the same structure as monobutyl phthalate. Similarly, BBP hydrolyzes to either monobutyl phthalate, which is active, or monobenzyl phthalate, which may not be biologically active. Thus, the RPF values of 0.53 and 0.52 for DIBP and BBP respectively are consistent with the monoesters produced by metabolism of each parent diester. This implies that a receptor may be involved, but PPAR alpha activation is likely not a key event because DBP is a poor activator of PPAR alpha. Higher molecular weight phthalates such as DEHP and DINP, which are good activators of PPAR alpha, have lower RPF values. The RPFs are also consistent with published evidence about relative potency of phthalates from the EPA fetal phthalate screen, such as the data in Fur et al. 2014. Finally, the committee agreed that the use of the BMD 40 to derive RPFs was well justified with caveats that we will describe below. Responses at higher effect levels, such as ED50 or ED25, traditionally have been used to estimate relative potency. Examples include the use of ED25 or ED50 to compare the relative potencies of carcinogens, and we will enter citations into the written response. This minimizes the effect of the dose response model on the RPF and ensures that RPFs are within the range of measured doses. With respect to phthalates, Ferdal used the ED50 to compare the effects on testosterone production across phthalates. The U.S. Consumer Product Safety Commission's Chronic Advisory Panel on Phthalates used the ED50 from Hannes et al. 2011 to estimate the relative potencies of phthalates with respect to male reproductive effects. Therefore, the use of BMD40 is appropriate for relative potency estimates and consistent with common practice in risk assessment. The committee also noted uncertainties with respect to EPA's approach. First, EPA was unable to confirm that the dose response curves were parallel or similar in shape and slope below BMD10 for DIBP and below BMD40 for BBP. Parallel dose response curves are preferred but not required for estimating RPFs. There are always uncertainties associated with comparing incomplete dose response data, and the RPF values for these chemicals may be different if lower doses were incorporated into the analysis. The lack of BMD5 and BMD10 values for BBP reduces the confidence in this RPF as acknowledged in the paragraph at line 889 in EPA's report. EPA reports that in contrast to the NASEM report, modeling with the updated version of Metaphor software using an additional data set did not result in estimates for BMD5 for BBP or DIBP. In the draft proposed approach for cumulative risk assessment of phthalates that was reviewed by the SACC in 2023, EPA considered both the RPF approach and hazard index approach and selected the RPF approach, noting that RPFs can be used even if the slope of the dose response curves differ, particularly if the underlying mode of action is the same, and that requirement is met here. However, EPA deviated from their conclusions in 2023 by selecting BMD40 to derive the RPF. In the draft proposed approach, EPA wrote, it is common practice to estimate RPFs closer to the low dose range of the dose response function, i.e. at the 5 or 10% effect level versus 50%. This practice is intended to reduce possible high-dose influences on estimated RPFs that may arise due to saturation of certain kinetic processes. However, this approach also carries an implicit assumption that the dose-response curve shapes will be the same below the selected response level. Because RPFs based on BMD5 or BMD10 would more adequately address this implicit assumption, then RPFs based on BMD40s, the committee suggests that EPA should provide additional information to the extent possible to assess the similarity of the dose response curve shapes below the selected response level. As the uncertainty in EPA's approach relates to the overall shape of the dose response curves for each chemical, the committee would like to understand whether EPA is able to report a slope parameter as supporting information. The concentration addition model described by Ryder et al. In 2005 requires EC50 and Hill slope for each chemical to calculate predicted mixture responses. Given that this approach has been applied to mixtures of phthalates and anti-androgenic fetal male reproductive toxicants in several papers written by EPA authors and cited in the cumulative risk assessment approach, using fetal testicular testosterone production data, it seems that a slope parameter could be calculated and included for comparison. This would presumably require a valid sigmoid model fit, and the committee is open to the possibility that it would not be possible for the best fit BMD model for each study. However, it would be helpful for comparison, even if the slope was not derived from the definitive BMD model used to generate the POD for the individual chemical. Second, studies for the BMD modeling in table 2-1 include 5 studies that measured fetal testicular testosterone content on GD19, 20, or 21, and 10 studies that measured ex vivo fetal testicular testosterone production. The committee expressed concern that testosterone content in the testis at the time of sampling is different from testosterone production as measured in media following ex vivo incubation, as in the standardized method published by Fur et al. Depending on the calculations, there is a question of the comparability between fetal testicular testosterone content and fetal testicular testosterone production. Finally, the committee identified 4 recommendations. So first, the committee generally supports the derivation of RPFs for DEHP, DCHP, DINP, DIBP, and BBP based on the ratio of BMD40 for testosterone production to the corresponding BMD40 of the index chemical DBP. Second, given the importance of similarity in the shape of the low end of the dose response curves, the agency should consider adding supporting information to compare the shapes of the dose response curves in table 2-4. If it is possible, EPA should report the slope parameter from the definitive BMD model or a sigmoid dose response curve as in Fur et al. 2014. The agency could also consider reporting the DIBP BMDL5 from the draft non-cancer hazard assessment for DIBP based on ex vivo testosterone production in Gray et al., or performing a new BMD analysis that allows for determination of BMD5 and BMD10 values for all 6 chemicals, as advised by the SACC response to charge question 5F. Third, the agency should clarify whether ex vivo testosterone and intratesticular testosterone data were analyzed separately to determine whether it was statistically appropriate to combine them in the testosterone meta-analysis and BMD analysis in table 2-1. This determination could be based on nonlinear regression analysis to test the null hypothesis that the regression lines are the same, or by two-way ANOVA in cases where the same discrete doses are present in both data sets. Fourth, and finally, if RPFs will be used to calculate hazard for other life stages, such as adult males or women above reproductive age, EPA should clarify with evidence that they were calculated based on data from the most sensitive life stage. And thank you. That was a longer response than I thought it would be, but that concludes our response.
Thank you, Dr. Spade. Let me check with the other discussants on this question. Dr. Babbage, you have anything to add?
No, I have nothing to add.
Okay. Dr. Chason? Dr. Chason?
I don't believe she was an assigned discussant.
Okay. She's on my
I'm sorry, I'm
list.
here. I couldn't get the audio to go back on. I apologize. Yeah, I have no further comments.
Okay. Dr. Ottinger?
Thank you, Dr. Spade, for excellent adjustment to the responses. I'd like to emphasize 2 points that were alluded to. One is that the low end of the curves and the high ends of the curves are particularly vulnerable to alterations, and that especially low dose effects need to be considered in the comparison. And then the other is an allusion to applicability of these data to protective effects for women, especially postmenopausal. And those are all considerations that should be at least acknowledged. Thank you.
Okay. Ms. Jenkins?
Hello. No additional comments. Great job, though. Thank you.
Okay. Dr. Wolf?
No comments. Thanks.
Okay. And Dr. David?
No additional comments. Thank you.
Okay. Anybody else on the SACC committee have any comments, clarifying questions? Dr. Fanning?
Yes, thank you. I was assigned to help review this question by Drs. Cobb and Kamel. So I have been part of the charge group so far. I just want to say, I think Dr. Spade's summary of the many scientific and modeling issues that we've been discussing was excellent. I don't have anything to add at this time. I think the uncertainties that were captured in Dr. Spade's summary are all things that we will be refining comment on in the final report. And thank you so much to Dr. Spade for pulling these ideas together.
Okay. Dr. Fox?
Yes, hi, Mary Fox here. So I just want to flag that maybe we need to coordinate a little bit between the response to 5F, actually, and Dr. Gentry, Dr. Ottinger, I don't know if you agree, with what was just read in. We should look at it, I guess.
I think so.
This is Dan Spade speaking. I may have gone rogue there in mentioning 5F as I was rewriting the summary this morning. So that, I think that was my comment, but yeah, but I'm happy to coordinate.
But yeah,
Yeah.
we can share and make sure we're at least being consistent.
Yeah.
Dr. Cobb?
I would like to echo Dr. Fox's comment, not to put Dr. Spade on the spot at all, but I think parts of 5, 10, and parts of 11, or maybe all of 11, all need to be somewhat harmonized so that we're not sending mixed messages, or if we are, it's clear the rationale for what differential recommendations are being made. But I think there's a lot of crosstalk between those questions surrounding the modeling of that BMD, whether it's a 5, a 10, or a 40.
Okay. Dr. Ottinger?
And I'm not a discussant for 11, but I'm seeing a lot of areas that people are treading on, over and over. And I think some of the ideas, and Dr. Spade, again, echoing everyone, you did a great job putting this all together. I think that if we can somehow crystallize the primary points, such as the curve fitting approaches, the statistics, and the manner in which a determination is made of similarity versus differences and what to distinguish, that would be very, very helpful across those questions. And perhaps, hopefully, I'm trying to help EPA, hopefully help EPA to be able to crystallize the salient points that are actionable.
Thank you. Any other comments from the committee? Okay, any clarifying questions from EPA?
EPA, no questions at this time. Thank you.
Okay, I think we are at a kind of a point where we need to stop for lunch for breakout sessions. So I will turn it over to Dr. Kamal.
Thank you. Yes, this is a good point to stop at. And we're going to start the breakout sessions with Dr. Jason's group. And it will be for 45 minutes. And then it will be followed by the breakout room for Dr. Martinez's group for 30 minutes. So that would be a total of 75 minutes. So then we can have our lunch break for 75 minutes, and then we will reconvene. Now, we can also arrange more breakout rooms, maybe around 3 o'clock, depending on how the charge questions are going. And if Dr. Fanning, you want to discuss with your group at 3 o'clock, please let me know if you want to do that. And if anyone else wants to also arrange for a breakout room around 3 o'clock, please let me know. All right. Well,
Dr. Kamal, will you remind us how to get into the room?
Okay. Please, Will or Kurt, can you explain how to get into the breakout room?
Yes. Look at the bottom of your Zoom client. You should see a button that says breakout rooms. Has 4 squares, like a window. If you click on that, you're able to see the different breakout rooms. And you can, if you scroll all the way down, you can manually select which breakout room you want to join. If you have any questions, just let me know.
Is there space for anybody additional to add, or are you already at the top end?
You can have as many as you would like. They just have to manually.
No, I'm asking Dr. Kamal.
Yeah, well, I didn't count exactly how many are left. So do you have a desire to join this group?
I was interested in 11, but I think that might be maxed out.
So 11, which is this one, Dr. Jason's group?
If that's all right, Chris, is that all right?
Yeah. Please join, and if we are over quorum, I or somebody else can drop off.
Okay.
Thank you.
Sounds good. All right, so then we're gonna meet after 75 minutes and enjoy your lunch and enjoy your discussions in the breakout rooms. Thank you very much.
Hello, everyone.
Hello.
See, we are back and going to get things started. I think the first thing we need to do is take a roll for the afternoon. Is that correct, Dr. Kamal?
That's correct.
All right. Let's see if everybody's back. Dr. Chasen?
I think some people may still be in the break room, actually.
Okay. Is there, let's see.
I see Dr. Chasen and Dr. Babbage only in the room.
Okay. Do we need to wait a minute or come back to Dr. Chasen?
Yeah, we can come back. Mhm.
Okay. And Dr. Cobb is not back yet. Dr. Ike?
I'm here.
Okay. Dr. Fong?
Yes, I'm here.
Dr. Fox?
Here.
Dr. Graham?
I am here.
Okay. Dr. Heiger Bernays?
Here.
Okay. Miss Jenkins?
Here.
Dr. Lee?
I'm here.
Okay. Dr. Merced Nueves?
Here.
Dr. Ottinger? Dr. Ottinger? Okay, I'll come back to her. Let's see.
I'm here. It just didn't go through. Sorry.
Who is that speaking?
Here I
I'm
am.
sorry. Oh, okay.
Yeah.
Okay. Dr. Samuel?
Yes, I'm here.
Okay. Dr. Babbage?
I'm here.
Okay. Dr. Chang?
Right here.
Okay. Dr. David?
Yep, I'm here.
Dr. Fanning?
I'm here.
Let's see. Dr. Martinez?
Hi, I'm present.
Dr. Rollins?
Yeah, I'm here.
Okay. Dr. Spade?
Here.
Okay. Dr. Wolf?
Here.
Okay, let's circle back. I see Dr. Chasen.
Yes, I'm here. Thank you.
Okay, and has Dr. Cobb joined yet?
It might be a few minutes more late.
Okay.
So I'm sorry, when you took the roll, do you mark how many were absent from the SACC?
I think the only one absent at the moment is Dr. Cobb.
Okay, then we have quorum and we can proceed. Okay.
Okay. Okay. All right. Okay. Well, I guess we will kick off. We are going to skip questions 11 and 12 today. There's still some more discussion and work ongoing with those, and we will plan to get back to them tomorrow. But we are going to move to the dermal exposure section and start discussions with charge question 13. Is EPA ready to read that into the record?
Ready. This is Giovanni Morales from EPA, and I'll be reading in charge question 13. Because phthalates have very low vapor pressure and absorb relatively slowly, a flux-based approach was followed in estimating dermal exposures. The flux-limited dermal absorption approaches for liquid, solid, and solid products and articles assume a constant rate of absorption of the phthalate. independent of the concentration of phthalate in the products and articles. EPA used the chemical absorptive flux determined through empirical data from literature or modeling in conjunction with surface area of contact and absorption time to determine potential dermal exposure. Please comment on the use of a flux-based approach for estimating dermal exposure to materials with a low volatility and low rates of absorption. See Appendix D of the draft environmental release and occupational exposure assessment for DCHP, Appendix C of the draft environmental release and occupational exposure assessment for DBP, and Section 2.3 of the draft consumer and indoor dust exposure assessments for DBP, DCHP, and DEHP. Thank you.
All right, thank you. And I will turn it over to Dr. Graham as our lead discussant.
Yes, thank you. The discussant's response to the question posed by EPA is that in general terms, it is appropriate to use a flux-based approach to estimate the dermal absorption of chemicals in the absence of experimental data. In this approach, a chemical's water solubility is used to calculate the absorptive flux, that is, the variable used in the assessment reports. Therefore, this approach assumes direct dermal contact with a saturated aqueous solution. Since the water solubility represents the maximum possible concentration, the assumption of a saturated aqueous solution makes the approach suitably conservative for risk assessment purposes. The flux-based approach assumes that mass transfer is limited by the rate of permeation, the flux, rather than the availability of the chemical delivery. In other words, the chemical loading must not be rapidly depleted during the exposure period. To satisfy this assumption, two key conditions should be met. One, the flux-based approach should not be applied to excessively long exposure durations. And two, the parameters used in the calculation, such as the permeability coefficient or absorptive flux, should be derived from high-quality studies in which flux limitation is valid. That is, studies that were carefully designed and conducted and where a high absorption fraction is not observed within a short period of time. For both DCHP and DBP, the first condition was met. The formula used in the assessment reports for DCHP, equation 2.1 of draft environmental release and occupational exposure assessment for DCHP, and the equation for DBP, equation 2-1 of draft environmental release and occupational exposure assessment for DBP, is appropriate only for relatively short exposures. This short term refers typically to a time shorter than 40% of the characteristic diffusion time. According to the EPA's Risk Assessment Guidance to Superfund, Volume 1, Human Health Evaluation Manual, Part E, Supplemental Guidance for Dermal Risk Assessment. The characteristic diffusion time is determined by a chemical's diffusivity, which is inversely related to its molar mass. Thus, smaller molecules are expected to have higher diffusivity and correspondingly shorter characteristic diffusion times. Based on calculations made on the data, if 40% of the characteristic diffusion time is used as the cutoff, it is about 18 hours for both DCHP and DBP. Therefore, it is acceptable to use the formula for exposure durations shorter than these cutoffs, like the 8-hour period used in the occupational assessment reports. However, for DCHP, it stated, quotes, the 1 to 24-hour absorption time range captures the dermal exposure scenarios duration used in consumer scenarios, and that's from lines 869 to 872. So the maximum durations within this applicability range should be less than 18 hours. So that should be checked within the within the assessment report. It's difficult to determine whether the second condition for using the flux-based approach was met or violated for DCHP, as no experimental dermal absorption data are available for this chemical. For DBP, however, 2 experimental studies exist: Doan and others, 2010, and Hoff and others, 2024, although only the former was cited in the EPA's assessment report. The 2010 report from Doan and others reported that 56.3% of an initial fixed loading of 1 milligram per centimeter squared of DBP was absorbed over a 24-hour period. This relatively high absorption fraction suggests that rapid depletion of the chemical mass may have occurred, indicating possible violation of the flux-limited condition. In contrast, the 2024 publication of Hoff and colleagues used higher initial loadings of 3.5 milligram per centimeter squared and 5.5 milligram per centimeter squared of DBP in an experiment over a 24-hour period. Although they did not directly report absorption fractions, we can still estimate the corresponding percent absorption to be 0.08% and 0.05% based on their reported absorptive fluxes, which were 0.11 microgram per centimeter squared per hour and 0.08 microgram per centimeter squared per hour, respectively, and a 24-hour exposure period. These percent absorptions are much lower than those reported by Doan in the 2010 publication. It should also be noted that the quality of the analysis in the Hopf 2024 study was enhanced by the additional comparative analysis of an in vivo absorption and uptake of the same phthalates, including DBP and DEHP. It is difficult to determine which study is of higher quality based solely on the limited information on experimental details provided in these 2 publications. However, it is generally understood that flux limitation is more likely to occur at higher dermal loadings. Therefore, if all else is equal, the data reported by Hoff and colleagues in 2024 may be more appropriate for use in a flux-based approach. This 2024 publication noted that DBP reached steady state in all experiments except for the water emulsification, indicating that the flux rate for this emulsification may not be representative of maximum or steady state flux. However, the reported flux for neat DBP was measured over a 24-hour period and may therefore be relevant to assumptions about exposure over a full day of exposure. The paucity of relevant data makes estimating dermal exposure from phthalate-containing products challenging. Employing dermal absorption flux is recommended for estimating dermal exposure rather than using percent absorption, as stated in Kissel 2011. However, assuming that the flux is independent of concentration is accurate only if the dermal loading is sufficiently high to saturate the dermal absorption process. EPA assumes a 7% emulsion of DBP represents a plausible upper bound for dermal exposure without explaining how 7% compares to actual formulations. Excuse me. The assumption that phthalates migration is mediated by an aqueous liquid, such as perspiration, it is a reasonable assumption. The vehicle has a significant effect on dermal absorption. Aqueous vehicles increase the absorption of hydrophobic chemicals because they favor partitioning to the skin. This phenomenon is supported in the results presented in the Hopf publication of 2024, in which the authors noted that DBP emulsified in water permeated skin in higher concentrations compared to the neat chemical. An alternative approach would be to use data on the transfer of phthalates from solids such as vinyl film, to skin. In this case, dermal absorption studies on near phthalates might be more appropriate for estimating exposure. Overall, EPA did a credible job of estimating exposure using the limited available data. John Kissel submitted some written public comments on the section from Appendix D of the DCHP Draft Environmental Release and Occupational Exposure document, which states, quote, using the work of Kissel 2011 to interpret the dermal modeling results for aqueous DCHP, the flux-based approaches are generally more scientifically sound than fraction-absorbed approaches. OECD 2004B, I'm not sure if that's the correct number, but is misleading with respect to finite and infinite dose. It correctly states that an infinite dose is one sufficient to preclude a decline in external driving force during the duration of the relevant exposure period. Then it conflates that concept with practical limits on vehicle loading observed in the field or employed in experiments. Dose status depends upon chemical load and driving force, observed or predicted flux into the skin, and exposure duration. A cut point used to avoid runoff that by itself says nothing regarding whether the dose is finite or infinite, end quote. Dr. Kissel also points out that absorption should vary with concentration below saturation, assuming reduced fugacity due to absorption to a solid matrix, that is, to soil, dust, clean clothing. This assumption is not relevant to pure powder where only one concentration is possible. In the case of liquid phthalates, concentration in solids or articles may or may not matter. If the phthalate is not actually absorbed in the material, but merely exists as a free liquid in the interstices of a matrix, then the driving force will be that of the pure liquid. However, the permeability coefficient may be reduced due to increased mass transfer resistance or the reduced intimate contact between the chemical and the skin. The discussion group's recommendations are to review the findings of Hoff and colleagues 2024 and evaluate whether those data may be preferable to those of Doan and colleagues 2010 for estimating dermal absorption in the flux-based approach. Second, review the written public comments by John Kissel and update the Appendix D Section 2 appropriately. This includes distinguishing differences in fugacity between pure powder, liquid phthalates, and solids or articles. Recognize that the permeability coefficient may be reduced due to mass transfer resistance. And third, add clarification and detail as outlined in the comments above. There are some additional clarifications that are needed, and the lines for each of these will be in the written document. So draft consumer and indoor dust exposure assessment for DBP. Do all the liquid products under consideration contain polymers? 2, describe the oil and water emulsion. Was the DBP in water or was there another oil? The vehicle can affect dermal absorption. For example, an oily vehicle may reduce absorption of a hydrophobic penetrant, such as DBP. Was the rate of absorption constant over 24 hours? How did the flux from the LCC and other studies compare to Doan and others? Were the methods in the newer Doan study differ from the previous studies? And in equation 2.1, the lack of a concentration term is problematic. Please explain what the effect of stratum corneum FA means. And in the draft environmental release and occupational exposure assessment for DBP, the methods matter more than a publication date. Split thickness skin is used because the penetrant needs to reach the upper papillary dermis to be absorbed. And did EPA consider using studies of vinyl films containing phthalates, such as Delsinger and others 1998, or Kawakami and others 2020? The various references will be included. Thank you.
Okay, thank you, Dr. Graham. Let me go to the other discussants. Dr. Babich.
I have a couple of clarifications. I think the Dysinger study was, I think EPA did use the Dysinger study, but it had a different name. I think there was a technical report and then a publication. So I think they're really the same study. One question, comment that I had in subsequent CQs was, I'd like to know more about the emulsion, because in the studies with the emulsion, the absorption rate was much higher than it was with either an aqueous vehicle or the neat application of the chemical. So that's why I would like to know more about the emulsion and what the effects of that are, and is that relevant to the product use area? Thank you.
We kind of lost the end there, Dr. Babich.
Oh,
Can
so
you repeat
yeah,
that final?
So with the emulsion, I'm wondering, is that really relevant to other product use scenarios, or to the products use scenarios?
Okay. All right. Thank you. Dr. Samuel.
Yes, thank you very much, Dr. Graham, for the summary. I thought that was very good. I actually have the same comment as Dr. Babich regarding the emulsion and the concentration. So the EPA had indicated that they had assumed, I believe they said, an upper bound of 7% for their emulsion. I did go back and look at the emulsion in the Hopf et al. 2024, it appears to be nowhere close to saturation, and maybe less than 7%, but it's not totally clear to me. So I do think that's a question. I would also have clarifying question for the EPA regarding the basis for that emulsion and what was the selection, because it could very well affect whether the water-based emulsion from Hopf et al. 2024 is relevant. I mean, typically, if there's a higher flux rate, but a much lower concentration, which then sort of balances out the total dose when one's looking at these data. But if it's not clear that it's apples to apples, I think there could be a potential question there. But otherwise, I don't have any other comments on this particular charge question, which was really focused on whether or not the flux-based approach was appropriate. Thank you very much.
Thank you. Dr. Lee.
Okay, I think all my comments are included. So very well done job. I don't have any actual comments.
Okay, thank you. And Dr. Heiger-Bernays.
I don't have any additional comments. Thank you. You read them really, prepared them, combined them, and I'm set. Thank you.
Okay. Anybody else from the committee? Okay, Dr. Cobb.
So thank you for that great discussion, and apologies for not being here exactly on time. I actually did have to go and eat some food. I do want to add one minor comment, and that is that having had the privilege of serving on this committee and some of you others having had the privilege of serving with Dr. Kissel on this and perhaps other committees, I give a lot of weight to what his comments are, and I encourage the discussants to do the same. And with that, I will close up.
Okay, Dr. David?
Just a follow-up to the comment that Dr. Babbage made. It is, you are correct. There was a report that for the American Chemistry Council that then turned into the Dysinger publication. So those are really one and the same experiment.
Okay, thank you. Anybody else? EPA, do you have any clarifying questions?
This is Giovanni Millers from EPA. We don't have any clarifying questions.
Okay, thank you. Let's see. I guess, Dr. Cobb, would you like to take over and carry us through the end of the day?
Sure. Were you just did 13?
13, and I think 14 is as far as we said we would go today.
Right. So I'll be happy to do that. If that is your preference, I'll certainly be happy to do that. So yes, charge. Well, before we do that, does EPA have any clarifying questions, or did you just ask that?
I asked that.
I'm sorry, I was trying to get caught up. All right, yeah, let's move on to charge question 14. EPA, please present that for us.
Sure. This is Giovanni Morales again from EPA. I'll be reading charge question 14 into the record. For DBP, liquid products, and DEHP, liquid products and solid articles, empirical dermal flux absorption data were available, sections 2.3.1 and 2.3.2 in the draft consumer and indoor dust exposure assessment for DBP, memo for DBP dermal absorption data in section 2.3.1 in the draft consumer and indoor dust exposure assessment for DEHP. Please comment on EPA's evidence integration and examination of the weight of scientific evidence, including strengths, limitations, and uncertainties, and resulting study selection for determination of dermal flux from contact with different forms and formulations of the phthalate, for example, solid, liquid, neat, aqueous, dilution, etc. See sections 2.1.2 of the draft non-cancer human health hazard assessment for DEHP, section 2.4.4 of the draft environmental release and occupational exposure assessment for DCHP, and section 2.4.3 of the draft environmental release and occupational exposure assessment for DBP, memo for DBP dermal absorption data, and section 2.3 of the draft consumer and indoor dust exposure assessments for DBP, DCHP, and DHP. Thank you.
Excellent. Thank you for getting that onto the record for us. And Dr. Graham is our lead discussant again.
Yes, thank you. In response, the discussion group states that the agency states that dermal absorption measured as percent absorption, permeability, or flux was highly variable in animal studies, depending on several factors such as species, study design, and formulation, but primarily influenced by the loading dose, with percent dermal absorption inversely proportional to the loading dose. Therefore, EPA selected the study by Hoff and others 2014 for determining dermal absorption of neat and aqueous DEHP because the study used metabolically active human skin, which retained esterase activity and the ability to metabolize DEHP to MEHP. EPA considered this study to be most closely approximate the dermal absorption of neat or aqueous DEHP in humans. However, the agency did not fully discount other studies, which also used human skin, and did not give a reason not to use weight of evidence approach. Using the Hoth study, a flux of 0.0013 microgram per centimeter squared per hour was calculated for neat DEHP, and a flux of 0.025 microgram per centimeter squared per hour was determined for aqueous DEHP. And this comes from lines 757 7 to 759 and 866 to 871 in the draft non-cancer human health hazard assessment for DEHP. EPA's effort to prioritize experimental data over predicted values based on the assumption that experimental data are more realistic does not fully convince all members of the SACC that experimental data are always of higher quality or inherently more reliable than model predictions. For example, the most important parameter in the flux-based approach is the absorptive flux, which is denoted as a capital J in EPA's assessment documents. This absorptive flux represents the amount of chemical penetrating through a unit area of skin per hour. Using DBP as an example, in the document, Draft Environmental Release and Occupational Exposure Assessment for DBP, 2 inconsistent values were used. And you can see this in table Appendix C-1. A high flux value of 0.0235 milligram per centimeter square per hour was used for dermal contact with liquid. This value was derived from an experimental study, Doan and others, 2010, that reports 56.3% absorption of 1 microgram per centimeter square of DBP over a 24-hour period, resulting in an average absorptive flux of DBP of 0.0235 milligram per centimeter square per hour. According to the EPA, this high flux value is representative of the average absorptive flux over the period of a workday for purposes of dermal exposure estimation in occupational settings. In contrast, a 75-time lower value of 0.000317 milligram per centimeter square per hour was used for dermal contact with solids. EPA states they used the study by Chemical Manufacturers Association from 1991 because it was the only study identified that tested the dermal absorption of DEHP from a solid matrix, the PVC film, and therefore provided relevant empirical data for these exposure scenarios with a calculated flux of 0.025 microgram per centimeter square per hour. And this came from the draft non-cancer human health hazard assessment for DEHP. This value was calculated using equation 2.1 for an 8-hour exposure to a saturated DBP solution. Applying DEHP as an emulsion increased the dermal absorption rate of DEHP by orders of magnitude compared to aqueous or neat applications. Note that even though the scenario is labeled as a contact with solids, the input parameters actually reflect contact with a saturated solution, not a solid form, as water solubility is used to calculate the absorptive flux. The problem is, these two values differ by a factor of 75, even though both of them are supposed to reflect exposure to saturated DBP solutions. The high flux value, even though it is experimental measurement, seems to be problematic for 2 reasons. First, if one back calculates the permeability coefficient using this higher flux, the equation 2.1, we would end up with a KP value of 2.55 centimeters per hour. This order of magnitude seems very implausible for most chemicals. Plausible range is less than 0.1 centimeter per hour. Second, this high flux value is orders of magnitude higher than more recently measured values by Hoff and colleagues in 2024, such as the 0.00011 and 0.000, that's 4 zeros and an 8 milligram per centimeter squared per hour. There's a table in the Hoff 2024 literature publication. And this is based on a higher initial loading of 3.5 milligram per centimeter squared and 5.5 milligram per centimeter squared of neat DBP, respectively, in an experiment over a 24-hour period. Of course, it is difficult to assess whether Doan or Hoff publications are of higher quality based solely on the limited information on the experimental details in these publications. However, it is generally understood that the flux limitation assumption is more likely to be violated at lower dermal loadings. As such, there are concerns about using the high flux value in calculations. The question remains whether the Hoff or Doan study should be applied to scenarios involving exposure to aqueous solutions or solid objects. Interestingly, the low flux value used by the EPA of 0.000317 milligram per centimeter square per hour, even though its calculated value happens to be at a similar order of magnitude as the more recent measurements by Hoff and others in 2024 publication. The agreement between the model prediction and measurements may partially support the higher credibility of these experiments. Another problem is that although the EPA considers different forms and formulations of the phthalate, that is, solid, liquid, neat, aqueous, etc., they fail to consider the direct dermal absorption of phthalates from vapor when phthalate-containing formulations or products are used. John Kissel submitted the following as written comments to charge question 14, quote, empirical evidence of direct dermal absorption of DBP from vapor is also available in the Weschler and others 2015 publication and rivals inhalation exposure. Failure to consider dermal absorption of phthalate vapor is potentially a significant weakness of this document. Ultimately, that depends on the relative magnitudes of inhalation, dermal contact, and ingestion exposures. From the existing published data, as noted in prior charge questions, DEHP inhalation exposure is relevant and important for workers, non-worker adults, and children. Noting a new paper that identifies SVOCs in air in rooms where babies and children sleep. Again, it's I believe it's Vasafar and others in 2025. Apologies for mispronouncing the name. The author saw that under the described settings, uptake of both phthalates, the DEHP and DEP, was documented through inhalation. The methods in this paper are well controlled and address some of the misinterpretations identified in the EPA review, namely vapor versus particle forms of phthalates. As with inhalation exposure, dermal absorption does not place the toxicant in the bloodstream in the same fashion as ingestion. However, Vasafar and others do estimate metabolite concentrations of MEHP and MEP, the toxic metabolites of the parent molecules, and EPA should consider the estimates from this study and from the Weschler 2015, Morrison 2016, and from the studies identified by EPA to do a bounding calculation to demonstrate that the root-to-root extrapolation to derive the POD from oral POD doesn't underestimate the dermal route of exposure, when both fugacity and absorption of direct dermal absorption of the phthalate. Some scenario assumptions regarding the use of DBP in products and the exposure scenarios of the products are questionable, such as the use of DBP in children's toys and shower curtains and contact with adult toys that may contain DBP. As for children's toys, DBP is not a good plasticizer of PVC, as illustrated in Rahman and Brazel 2004, and there is limited evidence from CPSC that children are exposed to DBP via toys, and that's from the 2014 CPSC publication. Also, the Danish Technical Institute study in 2010, cited by EPA in assessing exposure to DEHP from airbeds, shows that only one shower curtain in a sample of 10 contained DBP. In regards to adult toys, EPA uses the same contact scenario as with baby bottles, nipples, pacifiers, and toys. It is likely the baby products are designed with the expectation that mouthing and handling with fingers will occur. It is not clear that this would be the most important scenario for adult toys. The recommendations are: 1, EPA should aim to use consistent values across assessments, even if experimental data are not prioritized, particularly when such data seem to be implausible or unreliable. The second, EPA should review the findings of Hopf and others 2024 and evaluate whether those data are more appropriate than those reported by Doan and others in 2010 for estimating dermal absorption using the flux-based approach. Third, EPA should review new study by Hoff and other that also looked at diffusion, absorption, and excretion in humans following dermal exposure to DBP and DEHP. Given the criteria the agency set for acceptability of studies, the data from Hoff and others may be more appropriate than those from Doan and others who used the hairless guinea pig. EPA should review Weschler and other 2015, which contains empirical evidence of direct dermal absorption of DBP from vapor. And EPA should include direct dermal absorption of DBP from vapor, which rivals inhalation exposure. Without this, dermal exposure is significantly underestimated. Thank you. That is the end of our comments.
I believe Dr. Babbage is our next discussed.
Oh, I don't have any additional comments.
All right, Dr. Samuel.
Yeah, thank you very much, Dr. Graham, for the summary, and I don't have any further comments.
Dr. Lee.
Thanks for the nice summary. I don't have any additional comments.
And Dr. Heiger-Bernays.
Thank you, Dr. Graham. That was excellent. I have nothing to add.
Well, I would like to echo that thanks to you, Dr. Graham. If everyone has nothing to add, it means you did a really good job. So thank you again for that, that summary. And now let's go to the remainder of the committee to see if there are additional comments. All right, I'm not seeing any. So now we can move to EPA to see if you have any clarifying questions for us about this charge question.
Yes, this is Giovanni Morales from EPA. We don't have any clarifying questions. Thank you.
All right. Well, that brings us to a time where we need to decide where to go from here. I'm not sure. I am sure that we're not ready to cover many of the questions until we get to at least 617. And I don't know if I don't even know if Mike, you're ready to proceed with 17, or if EPA or the any of the folks at EPA thinks that that's advisable to skip that far ahead.
Well, This is Mike Babbage, and I'm ready. I just need to pull up the comments.
All right. Well, let me also ask EPA because they were they didn't want us to take certain questions in certain orders yesterday. So want to make sure we're not getting too far ahead of ourselves here.
Hey, Dr. Cobb, this is Giovanni Morales from EPA. We'd like to keep going if that's okay.
Okay. Well, I think maybe we'll take 17, but I don't think we're going to go further because we might do 18, but I don't want to go any further than that today. We've got a bunch of people that need to do writing and dialogue. Mike, can I ask you also, is 18 ready or do you need more time for 18?
It's ready.
Okay. Well, we might do 17 and 18 then, but let's see how that proceeds. And then we can get that charge question 17 up on the screen. I apologize for those running the AV in the background for getting that. Okay, so EPA, if you'll read that into the record.
Sure. Yes. Giovanni speaking again. I'll be reading in charge question 17 into the record. In section 2.3.2 and Appendix B of the draft Consumer and Indoor Dust Exposure Assessment for DEHP, EPA described the rationale, approach, and studies used to refine dermal exposure from airbeds. In section 5.1, EPA discussed the limitations and strengths of the refined dermal exposure assessment approach for airbeds. Briefly, EPA moved from the flux-limited dermal absorption approach to an approach which models dermal absorption using the specific phthalate concentration in the solid article. In this refined approach, material and chemical-specific partition coefficients and a barrier bedsheet between the airbed and the skin are incorporated. Please comment on the input data used in the calculations, the strengths and limitations of the dermal absorption refined approach for airbeds. Specifically, comment on the equations used to calculate the dermal flux from airbeds to skin for DEHP. Thank you.
All right. Thank you for getting that into the record for us. And then Dr. Babbage, if you'll lead us.
Okay, so overall, the model framework is scientifically reasonable. The equations look good in the inputs from published values. Moving from a flux limited to a concentration dependent approach should improve the accuracy and relevance of the exposure assessment. But we did have a number of clarifying questions. First, the distinctions among low, medium, and high intensity use contact are not entirely clear. Do these refer to contact duration or do they include DEHP content, which differs widely, or a combination of the two? So we would like some clarification in section 2.3.3. Now, the building of this exposure scenario does rely on many assumptions, and each layer of the exposure model compounds these assumptions. So a separate peer review of this exposure model by specialists may impart additional confidence that the model is constructed in a scientifically sound manner. And we ask, I think we just heard this one, did EPA consider the skin permeation study by Hopf et al. From 2024? This study applies to phthalates applied to the skin of volunteers and measured phthalate metabolites in urine. Next comment, the partition coefficient between air and PVC, the PVC airbed, K air hyphen bed, has different values listed in table 2-10. one table has 4 times 10 to the minus 11th, and then in the text, it has 3 times 10 to the minus 9th. So could EPA clarify which value is actually used in the calculations? And we also note that both of the values were calculated, but the assessment report does not provide any details to indicate how the calculation was actually done. The skin permeability coefficient for air phase transfer, K-air, was calculated by Lee et al., which had been further taken from Gong et al. Both studies used a calculation method similar to what's in EPA's consumer exposure model. Since the CEM model is already used to calculate aqueous permeability coefficients in the assessments that's covered in CQ 15, it might be more consistent and transparent to use the CEM model for the airface permeability coefficients as well. This consistency is important because the input PChem properties differ between Gong et al. And EPA's assessment. For example, Gong et al. Derived their physicochemical data, octanol, water partition coefficients, and so on using the SPARC model, whereas EPA used EPI-suite. As a result, even exactly the same calculations are applied, the differences in input data will lead to different permeability coefficients. And without this consistency, it becomes difficult to reproduce or verify the calculations. And then we have a few minor comments. Is maybe EPA can elaborate on why this is called a refined approach. I think it's in a way it's self-evident, but they might need to explain it for the reader. And one of the, I think in equation 2-3, the coefficient F doesn't seem to be defined. And also there's mention of a lowercase k and a uppercase k. Are they the same? We didn't see the units or dimensions for concentration in the skin or C subskin. And in the appendices, there's a column labeled risk estimate, and we would like to clarify whether this is the margin of exposure or some other measure of risk. And that's our comments on CQ 17.
All right, thank you for getting that comment read in. And now let's go to the associate discussants. Dr. David.
No additional comments, thank you.
Dr. Samuel.
Thank you very much, Dr. Babbitt, for the summary. I have no further comments.
All right, Dr. Lee.
I don't have any additional comments. Great job.
And Dr. Heiger-Bernays.
Neither do I. Thank you very much.
Well, then I need to echo the thanks as well for getting this read in early and with no additional comments from your co-discussants. Now let's go to others on the committee to see if there are additional comments. Seeing none, I actually have one, and I may have made this earlier, but I cannot remember if I made this comment before. There's actually some work, recent work out of Colgate University and others. I think City University of New York was part of it, where they looked at phthalate concentrations in the various materials, both fibers and plastics. I don't think they actually measured the flux. I think they predicted it based on EPA models. So I'm not sure it's exactly on point for this discussion, but I think it's important that EPA be aware of that study. And I will provide that reference to you, Mike. And I think I provided it to some folks in a couple of earlier consumer exposure questions, just to make sure it's covered. And I'm not going to be offended if it doesn't end up in this particular charge question.
I'll put it in.
Okay. Thank you. Now let's go to EPA to see if there are clarifying questions.
Thank you, Dr. Cobb. This is Giovanni speaking from EPA. I was wondering if we get a copy of that study as early as possible, so that we can reference it.
I will certainly do that, and I will send it to Dr. Kamal as soon as this is over.
Okay. Thank you.
Okay, well, let's now move to charge question 18.
Dr. Cobb, we have one more clarifying question to ask.
Surely. We're in no rush, and that's not a that's not a snarky comment. That's, hey, we are not in any rush. So if you need to change seats, we totally understand.
Yeah, we do the shuffle here. Hi, everyone. This is Kathy Denisio. We just like clarification. There was one comment Dr. Babich made about, suggesting additional peer review of the sort of refined model for the dermal exposure to airbeds. And we'd like some clarification on what you're asking for. Are you suggesting that we would need additional peer review of that model before being able to use it within this particular assessment? Or are you just sort of making a more general comment about that might be a beneficial thing to do in the future?
Well, I'm going to defer to the other team members. Ray, would you like to handle that?
Yeah, I think that was my comment. Sure. The point I was trying to make is that the agency frequently indicates that the construction of the model was peer reviewed, which is great. That's a wonderful thing. But because, as I said in my comments, because there are so many assumptions that are incorporated into those models, it would be great if somehow the output, you could have some kind of a reality check of the output, so that, okay, the model predicts such and such exposure. Well, is that realistic or not? And I'm not sure I have a good recommendation for how to do that reality check, but it would be worthwhile if it could be done. Does that help?
Yeah, that's helpful. I think I'm trying to think in the context again of what we can do in this assessment versus sort of more broadly moving forward.
Yep.
So it sounds like maybe it's more in the former camp where, or how should I phrase this? We'd like if you have one, a clear recommendation on whether we're okay to proceed with this evaluation with the model as implemented as it is, and potentially pursue additional verification of the model, in the future, or if we need to do that verification now before we can move forward with using it in this evaluation and finalizing this evaluation.
From my
perspective, I hear what you're saying, that we're not sure what we can do. We don't have a clear answer of what we would do. So then that puts us in a pickle.
And I certainly do not want to hold you back from proceeding with your task at hand. So it may be more of a general question that I think it'd be worth doing somehow if it's possible.
Yeah.
I don't know if I mean one of the advantages for this group of chemicals is that having biomonitoring data following some kind of exposure, whatever it is. There are a lot of biomonitoring data available, and typically they come from Europe, and because they can test people more than they test animals. So it's nice to be able to get that information and see if it somehow correlates with the output of the model. If there are no data available, no, then you go with what you got.
Okay. Okay. Thank you. That's helpful.
So, and we hear your request for some clear direction, loud and clear, and I'm going to try to charge all the leads with providing that and differentiating perhaps between whether this is something that is essential for this particular risk determination to go forward or risk assessment to go forward, or if this is a longer or intermediate term recommendation that we have that might actually not take effect until within the agency until future assessments. We will try to capture that in our readouts.
Great. Thank you so much.
Okay. So we just did 17 and 18, did we?
I think we're coming to 18.
Just did 17. Okay. Well, let's start with 18 then.
Thank you. This is Giovanni speaking from EPA. I'll be reading in charge question 18. In section 2.1.1 and 2.2.3.1 of the draft consumer and indoor dust exposure assessment for DVP and DEHP, EPA assessed exposures to each of these phthalates due to use of adult toys, both ingestion exposure due to mouthing of the articles and dermal exposure due to skin contact were quantified. Exposures due to expected direct contact with mucous membranes during the product's intended use were not evaluated due to a lack of modeling tools available to assess these exposure routes. Please suggest approaches for evaluation of exposure due to direct contact with mucous membranes. Thank you.
All right, thank you. And Dr. Babich, you are up again as our lead discussant.
Okay. Thank you. This was one of the more interesting charge questions. So anyway, direct exposure from direct contact with sex toys with mucosa is likely to be the most important pathway of exposure for these products. And I think we conclude that EPA should make every effort to quantify this exposure pathway. One option is to simply use dermal absorption data with skin as a surrogate for mucosa. This might underestimate exposure, assuming that the mucosa is more permeable, but at least you would have something, EPA would have something to work with. We also noted that the literature contains a number of studies on the absorption of chemicals through mucosa. Most of these focused on pharmaceuticals, especially peptides or other large molecules. However, some studies included small molecules. There were several of these, and included a range of chemicals. We also found that Britz et al. Studied hydrocortisone absorption through the forearm and the vulvar skin. And absorption was much higher through the vulva than through the forearm. And this highlights the fact that with dermal absorption, there's a great deal of variation in the anatomical site. We also conclude it may be reasonable to use a read-across approach comparing drugs administered by the vaginal or anal route with phthalates to estimate delivery and or absorption kinetics. It may be possible to make meaningful comparisons between dibutyl phthalate and or DEHP and vaginally administered drugs with low octanol water partition coefficient and low systemic absorption like fluconazole, or higher log P and higher chemicals with higher systemic absorption like progesterone. There is a good experimental paper from Human Reproduction on vaginal administration kinetics of progesterone. That's Levy et al. And these are similar studies, may provide information to assist EPA in developing a model for mucosal absorption. Drugs or chemicals with similar characteristics, log P and molecular weight to phthalates, may be most informative. And it also may be of interest to consider the relative permeability of skin and mucosa, as well as the effect of octanol water coefficient, partition coefficient, and molecular weight on mucosal absorption. Now, we found only limited information on use patterns of sex toys. Available studies include prevalence of use, and there are some publications that report on the duration of partnered intercourse that may be useful for comparison. And one exposure scenario that EPA might consider is in the report by Nielsen et al., which EPA cites. It involves sex toys used in combination with lubricants. The migration of rate of phthalates from sex toys with an oil-based lubricant was orders of magnitude greater than with a water-based lubricant. So that would make a big difference in potential for exposure. So our recommendations are make every effort to assess the risk from direct contact of sex toys with mucosa. One option is to use absorption data from skin as a surrogate for mucosa. A better option is to use data on absorption of pharmaceuticals through mucosa, along with read-across methods to develop a model that can be used for phthalates. And finally, to consider the migration data in Nielsen et al. And those are our comments.
Thank you very much, Dr. Babich. Now let's go to the associate discussants, Dr. Graham.
Sorry, I guess I'm on now. Okay. I have no further comments. Thank you.
All right, thank you. Dr. Chason? Dr. Chason, are you there? We can circle back. Dr. Spade.
My comments were captured in the summary. Thanks.
Dr. Martinez?
I don't have any further comments. Thank you.
Oh, and I have Dr. Graham again, but I don't think we need to hear a repeat. All right, so let's see if others on the committee have any comments. I see Dr. David's hand is up.
Yes, just a thought. And as Dr. Babbage was presenting his information, I did a quick look, there are data available for exposure of women to pollutants that might be in tampons. And it struck me, there's one, for example, of dioxin. So it struck me that that also may be something that the agency wants to look at, as at least, on the one hand, a pharmaceutical may be designed to be absorbed. On the other hand, you've got materials that aren't necessarily designed, but may be present. So something to consider.
Oh, thank you.
I'll just add that the work that I just described actually did some work with feminine hygiene products of various types. And I think even like undergarments for men and women of various materials, and they have phthalate concentrations, at least in those materials. I'm not sure if they have the, again, I don't think they actually measured flux. I think they simply measured content, but using the methods that have been described, the fluxes could be determined. So, Dr. David, that is an excellent comment, and one that I was actually going to bring up. So thank you. Dr. Hager-Bernays.
Yeah, I actually had the same comment. In fact, New York State has some regulations around sale of feminine hygiene products, specifically tampons, that contain phthalates. And so there are some data that are out there. I can provide some citations. So that could provide some additional information.
Great, thank you. Additional comments from the committee? So again, Dr. Babbage, thank you for getting all of that pulled together. And now we can turn to the agency to see if there are any clarifying questions for the committee.
Yes, this is Giovanni Marilis, again from EPA. No clarifying questions, but if you could please send us those citations ahead of time, that would be very helpful.
Excellent. Part of the reason I'm staggering around a little bit is I was trying to send those to Ala right now.
Okay.
So
thank you for that. Thank you.
And if Dr. Babbage or Dr. Hager-Bernays has any of that information, that would be helpful to get over to EPA as soon as possible.
I'll send it to Ala and CC George.
Excellent. Thank you. All right. Well, we are now to what it looks like the conclusion of tomorrow on my schedule, but we've skipped several things. At this point, some of our leads have asked for additional time for to work through some charge questions. And I think the majority of the day is going to be spent on that. But before we do that, I want to ask and circle back to the committee to see if there are any clarifying comments or questions that we have related to any of the dialogue that your comments may have gotten omitted. So let's open it up for any comments from the committee about things that may have gotten omitted today. Yeah, I do not see any. And the same opportunity for EPA. Are there any clarifications or requests from us other than those references we're really trying to get to you as quickly as we can from this last dialogue?
This is Giovanni speaking from EPA. We don't have any further clarifying questions. Thank you.
Okay. So now I'm going to ask our EPA officials that are more adept at FACA rules than I am. We have breakout groups that want to have this happen this afternoon and tomorrow. Should we have the breakout room this afternoon and reconvene this afternoon for a few minutes, or just reconvene tomorrow morning? Before we go into breakout rooms, I just need some advice on that.
Both ways work. It It depends on the lead discussants if they want to have some more time to go over the materials that they will be discussing. We can do that tomorrow morning. So both ways can work.
So one group has asked for time this afternoon, and two
Okay.
groups have asked for time tomorrow.
Okay. Then the group who
So,
asked for time for this afternoon, we can definitely have it. Mhm.
okay. And that was Dr. Samuel, and I will let her speak to whether that was, and we can also do this offline if you prefer. I just don't want to get us afoul of FACA rules. Charge questions 15 and maybe 16 are the ones that have a need to meet this afternoon.
Okay. Dr. Samuel, how much time would you need in the breakout room? And do you think we will be able to reconvene after your breakout?
Thank you very much. So I think 15 is okay. It's 16 that we have a little bit of some different comments, and I think it would be very helpful if that group is willing to maybe spend 30 minutes today discussing both Dr. Kissel's comments and the comments the collective comments from the group, but specifically for charge question 16, if that group would be available of discussants. I think 15 is okay. However, I am certainly open to a discussion on 15 if the other discussants would like to have that discussion. So I'll leave it open to anybody else to provide input.
So let me apologize, Dr. Samuel. I thought that that's one of the things you requested was 15.
I think as I think I mentioned, we're okay on 15, but if the other discussants would like to discuss that one, I'm very open to that. I think it's 16 is the one that I think would benefit from some discussion.
So let's do it this way without having a protracted discussion about this here. Is there anyone who's a discussant on charge question 15 who would like to have a breakout room discussion before we proceed to question 15? I don't see any hands raised. So I think we can do 15A and B. Is that correct, Dr. Samuel?
Oh, today I would prefer to do those tomorrow if possible, so I can properly just finish collating all of the responses, because I was focused on 13 and 14 to make sure those were ready for today. So if it's possible to do that one tomorrow.
So that's okay. So let's have a breakout for 15, for 16 at least, and you folks can decide if you want to, anybody from 15 wants to join. And Dr. Kamal, I don't see a way to proceed today with additional charge question responses. So I think we reconvene tomorrow for some clarifying comments and perhaps questions. And then we'll probably have to go right back into breakout groups because several of the charge questions still will not be ready until later than the published convening time.
Right, sounds okay. Just wanted to double check with Ms. Gibson if regarding FACA that would be okay not to reconvene today.
That is correct. We can adjourn the meeting today, and we can focus on getting our members into the breakout rooms, and then convening tomorrow. That is appropriate.
So, and let me say, just for safety, to keep our EPA colleagues and actually us out of a little bit of FACA trouble, when we reconvene tomorrow, and the charge questions are read out, if you can acknowledge that you met if you met in a breakout room today or tomorrow, that happened, that just puts it on the record that happened. And that we were monitoring quorum to make sure we weren't violating any of the rules.
That is absolutely correct.
So at this point, I guess we can set up a breakout room for Dr. Samuel's charge questions, and especially to make sure the folks in 16 have a chance to meet. And then do we officially adjourn for the day then, Dr. Kamal?
Well, the meeting will be ongoing for the breakout room, but for the rest of us, we can they can leave, and then we're going to reconvene tomorrow.
Excellent. Well, I'd like to thank everyone, the EPA folks, for getting all of this information to us and through the docket, and especially the peer review staff for working with the dynamic schedule that we have been trying to manage this week, and also Dr. Gentry for covering part of our moderation of this meeting. I really appreciate everybody's time. So let's move into our breakout rooms, and we will see the rest of the folks on the call tomorrow.
Thank you very much.
Thank you.
Adjourn the meeting.
So today's